Good evening, Sam.
Yeah.
Can we get started? You're muted.
Yeah.
Sam, you're muted.
Good evening, everyone. Welcome to day two of the proceedings of the HCM Symposium. And today we have an exciting line of talks laid out from the leading experts in their field. To begin with, we'd just like to start out with some introductory comments from Professor George Cherian, who was widely considered to be one of the giants in Indian cardiology. And he's a former head of the Department of CMC Vellore and has occupied many prestigious academic posts on 3 continents. Interestingly, when he was at Hammersmith, he published one of the earliest papers on beta blocker usage in hypertrophic obstructive cardiomyopathy. And I thought, and we think it would be quite appropriate to begin today's proceedings with introductory comments from Professor Cherian. Over to you, Dr. Cherian.
Greetings. I'm Dr. George Cherian, formerly at CMC Hospital, Vellore, and currently at the Narayana Institute of Cardiac Sciences, Bangalore. Brock and Thier first described hypertrophic cardiomyopathy in 1957-58. I have had a long-standing and continuing interest in HCM, having published in 1965 in the BMJ with Professor John Goodwin from Hammersmith, one of the early papers on the use of beta blockers. That was 55 years ago, and much has happened since. Most of you will be unaware of the raging controversy that went on for many years on the significance or otherwise of obstruction in HCM. Michael Criley from Johns Hopkins versus the NIH group. Around 1993, Doug Weigel introduced disopyramide and increased the armamentarium against obstruction. There has been so much more information from new investigation modalities and painstaking follow-up of patients. We now appreciate that microvascular dysfunction is one of the main causes of ischemia in HCM. It is being appreciated that a significant percentage of patients can have associated sleep apnea, and in some, management of OSA has even abolished the gradient. Yesterday, we had an update on the genetic studies. We now have a better understanding of the risk factors for sudden cardiac death, and appropriate use of AICDs has resulted in taming sudden cardiac death. We realize that septal ablation today has a very limited application along with pacing procedures. Better understanding of the pathology and abnormalities of the mitral valve apparatus has changed surgical techniques, and septal myectomy is now performed at many centers with almost 0% mortality, as you heard from Dr. Schaff from Mayo Clinic. This has resulted in a lifespan equaling that of normal people. New disease-modifying therapies are on the horizon, inhibiting cardiac myosin ATPase. Mavacamten is one such drug that is now on trials, and you will be hearing more about that later. Dr. Barry Maron showed us yesterday the gradual but clear decrease in mortality over the years. With the current understanding and treatment modalities, HCM is no longer considered a grim disease. Let us move on. Welcome to day 2 for updates on imaging, arrhythmias, and understanding of restrictive physiology, HCM in children, end-stage HCM, and novel therapies. I would like to compliment the organizers on the choice of topics and the speakers.
Hisham, you're muted, Hisham.
Welcome, everyone. So we'll move on to the first session for the day. And I'd like to introduce the chairpersons for this session. This session will be chaired by Dr. P.P. Mohanan, who's the director and head of the Department of Cardiology at the Westport High Tech Hospital at Trichy. He is also the current president of the Cardiology Society of India. Joining him is Dr. Ashita Bathur. He's the assistant professor in cardiac radiology at the Jayadeva Institute of Cardiovascular Sciences, Bangalore. And along with them will be Dr. Yash Lokhandwala, who is a senior electrophysiologist, who is currently at the Holy Family Hospital, Mumbai. Over to you, Professor Mohan, to introduce our first speaker.
Thank you, Hisham. Major advance in the hypertrophic cardiomyopathy has been in contemporary diagnostic imaging, which sort of gave us an idea about the phenotypes, which helped us in individualizing the treatment. And to discuss that, we have Dr. Ethan Robin, co-director of Hypertrophic Cardiomyopathy Center and director of PGIMER imaging. He has quite a lot of research works, more than 150 research works, 2,500 citations, and he comes from the Mecca of hypertrophic cardiomyopathy. Welcome, Ethan Robin.
Thanks very much for having me. It's really a privilege to be able to talk to you today about the role of cardiac MRI in evaluation of your HCM patient. Now, this is HCM by cardiac MRI. There is perhaps no cardiovascular disease in the world with the same degree of phenotypic heterogeneity as HCM. HCM, as you know, is a disease characterized by LV hypertrophy, and within HCM, this hypertrophy is diverse, really ranging from minimal and focal to massive and more diffuse. And the hypertrophy really can occur any place within the LV. This heterogeneity is in large part why CMR is the correct technique for characterization of this disease. CMR allows for thin slices that are contiguous throughout the LV, each with high spatial resolution. This allows to reconstruct the entire LV without obliquity. In each of these slices, blood is bright, myocardium is dark. And it's this sharp contrast between blood and myocardium that allows us to make precise wall thickness measurements any place within the LV chamber. Now, it's important to realize that when comparing echo and CMR, we are not comparing apples and oranges. Most commonly, these imaging modalities tell us the same story. In the majority of these cases, the maximum wall thickness is nearly identical between echo and CMR. But the issue is that there can be key discrepancies in individual patients that impact management. In this regard, there can be either over or underestimation of the degree of hypertrophy, either of which has the potential to have a major impact on management considerations for an individual patient. There are really three key regions of the LV that the echo not infrequently can have challenges in accurately characterizing. And we're going to talk first about underestimation of wall thickness in the anterior lateral wall, the posterior septum, or the apex. In this example, which is really a dramatic example of a discrepancy, the epicardial border and on the lateral portion of the LV can be difficult to determine. We estimate it's here, and that the maximum wall thickness is 18 millimeters. But in fact, you do an MRI and you see that the border wasn't here, it was all the way out here. In fact, this first patient has a massive LV hypertrophy, wall thickness of over 30 millimeters. Based on this finding on MRI, this patient underwent a primary prevention ICD placement. It's a good idea, as 2 years later, this patient had VF terminated by his device. You can have the same issues with the posterior septum, unclear where the epicardial border is, and you can miss massive hypertrophy. Again, by MRI, allows for much more accurate identification. On the last two slides, I show you how CMR changes management for risk stratification and maximum massive hypertrophy. But in each of these locations, it can also impact ability to accurately identify hypertrophy, leading to an HCM diagnosis. And that's the case here in this example, looking at the apex. At the apex, thoracic and pulmonary parenchyma can sometimes make it difficult to visualize the true apex. You can't see apical hypertrophy well here. Really, limitations not present by CMR, allowing for more accurate diagnosis. I just spoke about underestimation of wall thickness, but echo can also overestimate the wall thickness. The most common situation there is when you have either LV or RV muscle bundles adjacent to the septum that impact wall thickness measurements. For example, here, do an echo, you think the patient has massive hypertrophy at the wall thickness of 34 millimeters. When you do an MRI, you realize that part of that wall thickness was actually the crista supraventricularis, an RV muscle structure. And you exclude that in the wall thickness measurement, the wall thickness is only 23 millimeters. This is important as it more accurately identifies risk for that individual and that this might not be a high-risk scenario. In HCM, the typical mechanism of outflow obstruction is systolic anterior motion of the mitral valve with SAM septal contact. And CMR really helps us in better visualizing the outflow tract. And with that, can identify additional morphologic abnormalities that can contribute to obstruction. In this case, they have anomalous insertion of the papillary muscle directly into the anterior mitral valve leaflet with muscular apposition of the septum contributing to obstruction. What am I talking about? This is pathology in a different patient where you can see the pap muscle goes directly into the anterior mitral valve leaflet in the absence of chordae tendineae. As you can imagine, the identification of both SAM and muscular obstruction identifies an individual where alcohol ablation is unlikely to relieve obstruction for your symptomatic patient. Rather, an extended myectomy with thinning of the pap muscle, deep myectomy trough, allows the widening of the outflow tract that is needed. Again, abnormalities identified best by CMR to guide therapy. CMR also helps evaluate the mitral valve leaflets. There can be long leaflets in HCM, and in fact, that can be both the elongated anterior mitral valve leaflets and posterior mitral valve leaflets. And while you can see it on pathology, these examples, anterior and posterior mitral valve leaflet elongation, you can also accurately identify, accurately measure mitral valve leaflet length by CMR. So why do we care? The mitral valve leaflets that are elongated can be so elongated that it's the predominant mechanism of obstruction. In this case, this very elongated mitral valve leaflet sails into the outflow tract. As you can imagine, obstruction in this scenario is unlikely to be relieved by alcohol septal ablation. In fact, a traditional myectomy might not relieve obstruction, as there might not be enough muscle to resect, particularly in less substantial hypertrophy, as in this case, where the wall thickness is only 16 millimeters. And so in this scenario, not only might you need to do a myectomy, but potentially a plication of the anterior mitral valve leaflet. Plication sutures here shortens and stiffens the mitral valve to relieve obstruction. Obviously, the ultimate decision to plicate is up to the surgeon as to whether or not they feel they can take out enough muscle to relieve obstruction. Our experience at Tufts is when the mitral valve leaflet is over 32 millimeters, and the septum is on the thinner side, less than 17 millimeters, is when our surgeon, Hassan Rastegar, really strongly considers plicating. CMR can also provide a roadmap of hypertrophy. Helps the surgeon identify how thick the muscle is, when does it thin out, how far down is myectomy trough, needs to go, really helping in surgical planning. In no patients is this issue more important than in the unique patient subset where they have normal or near normal wall thickness measurements, but have obstruction. In these patients, septal contact is present. They also tend to have other morphologic abnormalities that contribute to obstruction, such as apical basal muscle bundles inserting into the anterior septum and narrowing the outflow tract, elongated anterior mitral valve leaflets, which we spoke about, or bifid pat muscles that pull the anterior mitral valve to the septum. Despite minimal hypertrophy in these patients, when they become severely symptomatic, you don't need to replace the mitral valve. Here's our experience, 36 patients, thin septums, advanced heart failure symptoms. Surgeon did a shallow myectomy, but also really focused on the outflow tract and mitral valve to relieve obstruction. Each patient had improvement in symptoms, including 70% who went from class 3, 4 to class 1. Done safely, without VSD, no need for mitral valve replacement, albeit given the thinner septum, higher risk for heart block, and need for pacemaker. So, spoke about the role of CMR in HCM phenotype and outflow morphology. Now I'm going to talk about this role CMR plays in the identification of high-risk HCM patients who deserve consideration for primary prevention ICDs. I know that Marty Marin discussed this at length during his conference talk yesterday, so I'm not going to spend too much time on this topic. However, I really want to point out that of the 7 major risk markers that we use in risk stratification, Tufts, 4 of them are imaging-based with great utility of CMR in the identification. In this regard, a risk marker seen only by CMR is extensive late gadolinium enhancement, LGE. LGE represents our ability to non-invasively characterize the myocardium and identify areas of scarring and expanded extracellular space, i.e. what we see with LGE. And with the increase in amount of LGE, the risk for sudden death events increases as well. And this is in 782 patients without other risk markers. As you can see, as the amount of LGE increases, so does the risk of sudden death events. In this regard, we identified 15% LGE within the LV as a cut point for unacceptable increased risk. However, it's important to realize that there's a continuous relationship between percent LGE and sudden death risk that must be taken into account. And this strategy really allows us for a measure of individualization and decision-making regarding prophylactic ICDs and what degree of risk is considered unacceptable for an individual patient. It's also important to realize that extensive LGE is not just a marker for sudden death events. It really also is a marker for development of end-stage HCM with systolic dysfunction, patients at risk for progressive heart failure symptoms, and need for transplant. And we define systolic dysfunction in HCM by an ejection fraction of less than 50%, which is really markedly reduced when you consider that the ejection fraction in this disease is typically hyperdynamic. At this EF cut point, it's an important marker with patients at nearly five-fold increased risk for sudden death events as compared to patients with normal EF, much higher risk for progressive heart failure, as well as HCM mortality. And because of this, these patients deserve consideration for primary prevention ICDs and early evaluation for heart transplant to extend longevity. Importantly, though, CMR allows us to prospectively identify at-risk individuals by identifying extensive LGE before they develop systolic dysfunction. Amount of LGE increases, so does the risk for developing end-stage disease. And identifying patients with extensive LGE who need close follow-up for this complication. Lastly, we want to talk about apical aneurysms, thin-walled, akinetic aneurysms at the apex of the LV, really identified in this disease best by CMR. As Dr. Marin discussed yesterday, CMR has really done almost everything from this patient subset, taking it from an unknown to identifying that these patients are at high risk for adverse events, particularly arrhythmic sudden death, treatable with ICD, primary prevention, as well as embolic events and clot formation in the aneurysms, leading to consideration for anticoagulation and prevention. And with these primary prevention strategies of ICD and anticoagulation, it's really transformed this high-risk subgroup into one that is treatable with low mortality risks, no different than HCM patients without aneurysms. So I just took you why we do CMR and HCM. It more reliably characterizes the HCM phenotype. It helps us define the mechanism of outflow obstruction, identifying patients who are not good candidates based on anatomy for alcohol ablation, really enhancing surgical planning for myectomy. In addition, it identifies high-risk subgroups for sudden death, allowing us to consider primary prevention ICDs, protection. So who should get a CMR? I mean, I think the data I just presented really helps justify the routine use CMR in HCM patients, which is really our practice at Tufts. Thank you very much.
Excellent talk, and over to Hisham.
Hi, it's my pleasure to introduce Dr. Ajay Bal, professor in the Department of Cardiology, PGIMER, Chandigarh. And he's going to be talking about restrictive cardiomyopathy, which is restrictive physiology of HCM, which is a rare but very interesting and topic. So over to him.
Good evening. Today, I will be speaking on idiopathic restrictive cardiomyopathy. Restrictive cardiomyopathy is a rare disorder. However, three conditions are commonly found to cause restrictive cardiomyopathy in India. Probably the commonest is idiopathic restrictive cardiomyopathy. The other two relatively common conditions are amyloidosis and endomyocardial fibrosis. Idiopathic restrictive cardiomyopathy has a strong genetic basis, with mutations being identified in over half these individuals. Certain types of amyloidosis also have a genetic component, but I will not be covering amyloidosis today. Endomyocardial fibrosis is by and large an acquired disorder. Now, what is the histology of idiopathic restrictive cardiomyopathy? If we look at endomyocardial biopsy-based study, what is seen is that interstitial fibrosis and myocyte hypertrophy are seen in over 80% of these patients. Endocardial fibrosis is seen in around half of these patients, but myocyte disarray is not commonly found in endomyocardial biopsy sample. However, if we look at samples where there is a full thickness examination, for example, hearts which are taken out at autopsy or at the time of transplantation, we find that extensive myofiber disarray has been reported in these samples. So in this study, 7 explanted hearts at the time of transplantation were studied. Interstitial fibrosis and myocyte hypertrophy was present in all, and myocyte disarray was present in 3 out of the 7 cases. So if we compare the histology of idiopathic restrictive cardiomyopathy and hypertrophic cardiomyopathy, we find that the histology is very similar, and interstitial fibrosis is seen in almost all patients in both the disorders. Other common findings are endomyocardial fibrosis, myocyte hypertrophy, myofiber disarray, and occasional endocardial thickening. There are very few distinct histopathological findings which would distinguish idiopathic restrictive cardiomyopathy and hypertrophic cardiomyopathy. This suggests that both these disorders have a similar pathophysiological basis. Now, idiopathic restrictive cardiomyopathy was first reported to be a genetic disorder in 2003, where 9 patients with restrictive cardiomyopathy were screened for mutations in the troponin I gene, and 6 out of these 9 were found to have mutations. This was a study which was carried out in Caucasians. The histology reported showed interstitial fibrosis and myocyte disarray. This was a large study. I was also involved in this study, which looked at a cohort of hypertrophic cardiomyopathy patients. So the phenotype which was looked at was a restrictive phenotype with only a mild left ventricular wall thickness of less than 15 millimeters. So a large cohort of over 1,200 patients from 688 families of hypertrophic cardiomyopathy was screened, and it was found that around 1.5% of this entire cohort had a restrictive phenotype with only a mild left ventricular wall thickness. These patients had a similar age as compared to the rest of the hypertrophic cardiomyopathy cohort, but these were much sicker patients. They were in a worse NYHA class, they had a larger left atrial size, they had a lower event-free survival rate of only 56%. Atrial fibrillation was seen in around 3/4 of these patients, and they had a poor exercise capacity. And if we see, they had on follow-up, they had a higher all-cause mortality and heart transplantation. They had a higher rate of cardiovascular death or ICD discharge, and they also had a higher rate of heart failure death or heart transplantation. which indicates that if a HCM patient has a restrictive physiology, the outcomes, whether it is sudden death or whether it is heart failure related events, is much worse. So, out of these 19 patients came from 16 families, and 15 of these families were genotype. And what was surprising is that troponin I mutations were found in 4 of these families, and myosin heavy chain mutations were found in another 4. No mutations were found in troponin T, tropomyosin, or myosin binding protein C. So this was a relatively surprising finding, because if we look at the overall hypertrophic cardiomyopathy cohort, we find that troponin I mutations are reported in only around 3%, whereas troponin I mutations were far more common in the restrictive cohort. Now, this was another study which screened patients with restrictive cardiomyopathy. These were children, and they were screened for mutations in sarcomeric genes. And again, what was seen was that troponin I was the commonest gene in which a mutation was found. So now, just to highlight the spectrum of restrictive cardiomyopathy and hypertrophic cardiomyopathy, I will just show one of our Indian families. And this girl came to us at the age of 15 years. She had a left ventricular wall thickness of 17 millimeters with a restrictive physiology. Her father had died at the age of 47 of refractory heart failure. He had been sick for 20 years. He had a restrictive cardiomyopathy with a normal left ventricular wall thickness. Her elder sister had died at the age of 16 years of sudden cardiac death. She also had a restrictive cardiomyopathy with a normal left ventricular wall thickness. So we have a family in which 2 members have restrictive physiology with normal LV wall thickness, and 1 child has got a restrictive physiology with a left ventricular hypertrophy. And this girl had typical findings of biatrial enlargement with normal size ventricles on echo, and the histology typically showed interstitial fibrosis and myocyte disarray. She was found to have a mutation in troponin I. This mutation had only been reported once previously, and this was from the first study, the 2003 study. It was a de novo mutation in a Caucasian. That means both his parents did not carry the mutation. The functional studies in transgenic mice have been carried out of this particular mutation, and the main alteration found was impaired cardiac relaxation. The mouse model also showed that the ejection fraction was significantly reduced, although all our patients had a normal left ventricular ejection fraction. So let us look at the spectrum of restrictive physiology and hypertrophic cardiomyopathy. Now, hypertrophic cardiomyopathy patients may have mild hypertrophy or normal LV wall thickness or severe hypertrophy. They have impaired diastolic dysfunction, which may vary from mild to severe. If the diastolic dysfunction is severe, these patients get labeled as restrictive physiology. Now, this is a diagram which is depicting absolutely the same physiology. We have a spectrum of hypertrophic cardiomyopathy. From left to right, it varies from normal left ventricular wall thickness to severe left ventricular hypertrophy. From bottom to top, this spectrum represents mild diastolic dysfunction to increasingly severe diastolic dysfunction. And the patients who have the most severe diastolic dysfunction are said to have a restrictive physiology. And around 1 to 2% of hypertrophic cardiomyopathy patients have got a restrictive physiology. If these patients have got a normal left ventricular wall thickness, they will be labeled as idiopathic restrictive cardiomyopathy. If their LV wall thickness is increased, they have left ventricular hypertrophy, they will be labeled as hypertrophic cardiomyopathy with restrictive physiology. So as we can see from this diagram, these disorders, that is idiopathic restrictive cardiomyopathy and hypertrophic cardiomyopathy, are similar disorders. The only thing is maybe the difference of a few millimeters in the left ventricular wall thickness. So to summarize, idiopathic restrictive cardiomyopathy is caused by sarcomeric gene mutations and does not have hypertrophy. If hypertrophy is present, then we would use the term hypertrophic cardiomyopathy with restrictive physiology. So now let us, what we have reported, what we have discussed so far is mutations which are based on conventional Sanger sequencing. So let us look at some of the studies which have been based on next generation sequencing. These may be either panel based or whole exome sequencing. So a Russian study which looked at 24 patients with idiopathic restrictive cardiomyopathy found mutations in 13 of them, and the common genes in which mutations are found were myosin heavy chain and myosin binding protein C. In this, troponin I mutations was found only in 2 of these 13 patients. Another study has reported titin mutation in a family of 6 affected individuals. Another large study of 32 patients identified mutations in around 60%. That means restrictive cardiomyopathy mutations are found in over half the individuals. And what was seen was that myosin heavy chain was the commonest with 4 mutations, and troponin I was found only in 1 of these 19 individuals. So when we look at the next generation sequencing data, we find that the troponin I mutations may not be that common. Another genetic cause of restrictive cardiomyopathy is desminopathy, and one should specifically suspect desminopathy if atrioventricular blocks are present. We must remember that desminopathy is not evident from routine histopathological examination as seen in H&E staining. They have to be specifically identified with immunohistochemistry, and these are due to mutations in desmin and alpha B crystalline genes. So idiopathic restrictive cardiomyopathy has sarcomeric mutations, sarcomeric gene mutations in over half the patients. Troponin I mutations are disproportionately high. So what is in a name? Around 50% of idiopathic restrictive cardiomyopathy have sarcomeric gene mutation. RCM and HCM are very similar etiologically in these patients, and different terminologies only reflect differences in LV wall thickness. Less than half the so-called idiopathic restrictive cardiomyopathy cohort are today can be labeled as truly idiopathic, in which no mutations have been found. Thank you. Thank you so
much. It gives me pleasure to introduce an old friend and a world-famous cardiologist, Sam Asirvatham, who has done pioneering work in many fields of arrhythmia. And let's listen to what he has to say today in AFib in HCM.
This is Sam Asirvatham, electrophysiologist, Mayo Clinic. Thank you for the opportunity to review for you on managing atrial fibrillation in hypertrophic cardiomyopathy. A quote from Dr. Braunwald, hypertrophic cardiomyopathy is a unique disease, and whether we're dealing with the entity itself, ventricular arrhythmia, atrial arrhythmia, there are features that have to be considered specific to this patient population. I will just say off the bat that we all know as invasive electrophysiologists that ablation for atrial fibrillation and atypical flutter in hypertrophic cardiomyopathy, like ventricular tachycardia, is among our least successful and more challenging. So with that as background, I'll review over the next 15 to 20 minutes a personal perspective from practice of what are some of the things to consider as to why it's difficult, and maybe in some situations suggest some solutions both for now and in the future. So one of the problems when we talk about atrial fibrillation and hypertrophy is atrial itself is a heterogeneous disorder, but hypertrophic cardiomyopathy is very heterogeneous, with some patients that really kind of are borderline normal, others with severe hemodynamic and multiple arrhythmia issues. The more sick patients also are less tolerant of procedures, but they are also the ones who are less tolerant of atrial fibrillation. And often we are pushed to try to rhythm control and having a team approach with hemodynamics, clinical management, sometimes just gives us that extra bit of time during procedures to get better result. Just like other patient populations with hypertrophic cardiomyopathy, we're always thinking about the trigger, what that substrate is that initiates atrial fibrillation, and what's maintaining it. The difference is we always expect and deal with a lot more of the maintenance substrate. But the message, I think, to an electrophysiologist is, yes, there is more substrate, but it becomes even more important to understand what's initiating the arrhythmia and try our best to solve that. So although this is the problem, the maintaining substrate, we have more control about trigger elimination and do our very best to try to minimize that. In general, it's also important to understand why patients with hypertrophic cardiomyopathy are so symptomatic. Part of it is the arrhythmia itself, but part of it is also heart rates. And heart rate control in patients with hypertrophy, even with successful procedures to manage breakthroughs, is very important. When we try to maintain sinus rhythm, we often have to start off discussing with the patient a combined approach of catheter ablation, devices, and drugs. It's unusual with severe hypertrophy that just one of these is enough. We will discuss about the limitations of catheter ablation in this patient population, but drugs also have limitations. Several are just contraindicated or very difficult to use when we have substantial hypertrophy, especially drugs like flecainide or propafenone. The main issue is unique propensity for proarrhythmia. The more the hypertrophy, the more the scar, and the more the differences between the endocardial and epicardial layers of the myocardium, the more likelihood for developing polymorphic arrhythmias. This is true with any agent, and that is often why you see patients with refractory symptomatic atrial arrhythmias and hypertrophy on amiodarone, perhaps the least likely to give us polymorphic ventricular tachycardia. Now, in hypertrophy, when we think about an ablation approach going for substrate versus trigger, we are always estimating that a bulk of the atrial myocardium is going to have substrate abnormalities. But our initial approach is a combined one with drugs that may help with substrate, and then careful and sometimes repetitive addressing of triggers. And the reason for this is, like other cardiomyopathies, but especially with hypertrophy, we do have increased left atrial pressure and dilation of the atria, pulmonary veins, and other thoracic veins. So this dilation increases not only the surface area, but the higher likelihood of having ectopy and triggers. This is something that we are very good at addressing with our approaches for ablation. One word about pulmonary venous anatomy in hypertrophy, that when left atrial pressures increase, pulmonary venous pressures also increase. But sometimes there is left atrial hypertrophy and increased wall thickness in hypertrophic cardiomyopathy. Thus, the major areas of dilation may be the proximal pulmonary veins. So sometimes we see pulmonary varices, large pulmonary veins that more chance of recurrent conduction after ablation, etc. In our classic approach to pulmonary vein isolation, it still remains the same with hypertrophic cardiomyopathy, but we have to understand that there is more tissue because of this hypertrophy and dilation from higher pressures, that our isolation circle around the pulmonary veins tends to be larger and more difficult to keep as permanent isolation without recurrence of conduction. So extra time waiting at the end of the procedure, adenosine testing, and then trying to keep all our touch-up lesions all on the same circle to be as certain as we can be is important. It's not so much the thickness of the tissue that's more of an issue for linear ablation, but size of the atrium, size of the pulmonary veins, but with large amplitude signals still being present where there isn't fibrosis, makes this a challenging set. I think it's very important in hypertrophy to take the time after pulmonary vein isolation to look for other triggers. Substrate, only so much we know how to do, but if, for example, in this case, there was recurrent atrial fibrillation after pulmonary vein isolation, catheter deep in the SVC shows the earliest signals, we have a target for eliminating another trigger. Another patient data here showing continuous ectopy. When substrate is bad, ectopy becomes worse because it's easier for ectopy to trigger sustained atrial arrhythmias. So after we finish our pulmonary vein isolation, if we see evidence of persisting ectopy, it's good to map it in this particular patient from the vein of Marshall region. Just a word about ablation with thick atria. More than dilation, with thick atria, the muscle itself is thicker. However, that thickness stops at the level of the pulmonary vein. So one of the temptations is, because we have trouble trying to finish the circle in the thick atrium, we inch closer to the vein, especially in patients with long-standing high LV pressures, long-standing hypertension, aortic stenosis, and especially hypertrophic cardiomyopathy. We have to resist this because once you get into the vein, it's unopposed endothelial proliferation, and if we take more time at the antrum to ablate, we have less risk of getting stenosis. Another point about how the left atrium enlarges with pressure overload, it tends to enlarge primarily in the roof and posterior wall, where there is unsupported pericardium, that is the oblique and transverse sinuses. So one of the issues from that is indentation into the esophagus, so have to be more careful than we usually are with posterior lesion sets in patients with hypertrophy. Now, tissue fibrosis with catheter-based or imaging techniques, especially with long-standing hypertrophy, uncorrected hemodynamic issues, is the rule more than the exception. The early stages, we may not see much, and just trigger-based ablation and a drug may be helpful. In very late stages, there can be so much fibrosis that you may not even find signals in one or more pulmonary veins, sort of like an auto-isolation. But the intermediate is the challenge, and where we have to combine drugs, perhaps some substrate modification, and with as the days go by and we have more refined techniques of trying to understand which of these substrate abnormalities not only is viable, but can sustain rotating wavelets, rotors that we can target for ablation. One approach that's attractive is autonomic modulation. Many surgeons, when they do surgical procedures for patients with hypertrophy, will consider ganglia clamping and ablation rather than the maze procedure. Others will do a combination of both. And the reason for this has to do with creating a maze in the atrium, as we'll see in a representative case when I finish this presentation, can be problematic in terms of atrial transport function and timing with the left atrium. Word about contact force mapping with hypertrophy. Near the annulus and in some other regions, because of this thickness of the atrium, we can overestimate the contact force in certain locations in this patient population. Now, generally, those areas where we see high contact force is where there's thin myocardium. But in hypertrophic cardiomyopathy, we may have to keep re-zeroing and looking with intracardiac echo, electrogram reduction, in addition to the contact force measurement. Just a word about coronary sinus ablation in patients with hypertrophy. In the normal heart, the right atrium is slightly larger than the left atrium. So as a result, our coronary sinus and right atrial are on the same floor. As the left atrium enlarges, like with hypertrophy, we then have the floor of the CS may be lower than the floor of the right atrium. This will make catheters, when we enter the CS, point more towards the roof and may limit the amount of ablation we can do because of risk to the AV node, particularly in the proximal CS. Pectinates, left atrial ridge, especially the distal pectinates, tend to be larger in anyone with pressure overload, but independently can be larger with thicker myocardium in some variants of hypertrophic cardiomyopathy. This can be especially an issue when we are doing the anterior part of the circle around the left-sided pulmonary veins. This can produce difficulty in balancing the catheters and make us tend towards ablating closer to the pulmonary veins. Again, this has to be resisted, just more time, more titration of energy, and to finish the circle in its usual location. Both with hypertrophy and restrictive myopathies, when the left atrium enlarges, the posterior wall and roof the posterior wall and junction with the roof tend not to enlarge as much as the vestibule. Since the vestibule and appendage tend to be able to take up this pressure, lower impedance structures, we should be prepared to do longer lines when we do linear ablation in patients with large left atria from pressure overload. Because the appendage is thick, the pulmonary vein potentials can be more confusing in patients with hypertrophic cardiomyopathy. Simple thing can be to just change the site we're pacing in a patient who is in sinus rhythm. If there is a change in the intervals between the signals we're seeing, LA and something else, it's not pulmonary vein, it's an overlapping structure like the left atrial appendage. We can confirm further by pacing in the left atrial appendage to assess that. The thickness of the pulmonary vein sleeve, like in this patient during CS pacing in the right and looking at the left pulmonary vein, can also be thicker, and you can see multiple segments of pulmonary vein potentials. And when we ablate, we should see all of these move out together and disappear. Presumably, these are thick sleeves in the pulmonary veins, especially in the first order branches. The same issue of sleeves and thickness in hypertrophy is also true of the coronary sinus. So this is a patient, hypertrophic cardiomyopathy, recurrent left atrial flutters, no electrograms along the line, and appearance of conduction block when we terminate flutter. But flutter still persists, and high output pacing on the posterior wall can entrain the flutter. This is a situation where the coronary sinus myocardium is able to sustain conduction even with good endocardial lesions. So just to keep in mind this possibility and consider ablation within the coronary sinus. Just a quick words more for the future and things to think about. Electroporation may give us the ability for myocardial thickness related problems, both in the ventricle and the atrium, actively being explored in the ventricle, and probably will have a role in the atrium as well. Studies have not looked at myectomy patients. What is the benefit in terms of atrial enlargement? Anecdotally and from practice, it does not appear to give us much of a benefit, probably because LV and diastolic pressures tend to continue. Most of you are aware, but a word about the dangers of extensive ablation or the maze procedure in patients with hypertrophic cardiomyopathy. Relaxation is abnormal in the ventricle, and timing between the LA and LV is very important. Remember, there is delay from RA to LA in patients with diseased hearts. As a result, if we also have lesion sets, then the LA can get activated so late that the LA and LV contract at the same time. These patients with hypertrophy feel worse after successful ablation than they do in atrial fibrillation, which was already not good. An example of this phenomena here, looking with inflow Doppler, you can almost visualize two different atrial activations. And this late atrial activation, if it times with left ventricular pressure, left ventricular contraction, can increase our pulmonary pressures. We can also see some evidence of this on the right side. Here with invasive hemodynamics, when sometimes the best solution if this happens is to pace in a way that the RA and LA are getting activated at the same time. And this was accomplished with pacing from near the coronary sinus atrial veins. And we can see that even with exercise, you tend to maintain a much less filling pressure and translation to improvement in symptoms when you find this. So here showing that just in sinus, this difference, higher left atrial pressure with direct measurement, and then when we synchronize the atrium and pre-excite, relatively pre-excite left atrial filling, you can get a lowered pressure and improved symptoms. Something to keep in mind when post-ablation or post-maze symptoms have worsened in our patient. Thank you very much for your attention. I know I won't be able to be there for the question and answer session, but happy to discuss when we are meeting together, perhaps in person in the not too distant future.
Good evening. It now is my privilege to introduce a friend of 3 decades, Dr. Narasimhan, huge contributions in the field of electrophysiology and a pioneer in India and a very good clinician scientist. Over to you, Narasimhan.
I've been given the task of speaking about ventricular arrhythmias in hypertrophic cardiomyopathy, especially after the ICD is implanted. How do you recognize and treat these patients. So I'm going to be talking about the prognostic and therapeutic implications of non-sustained ventricular tachycardia, optimization of ICD in terms of device programming, briefly about role of pharmacological therapy and lifestyle changes, and strategies in patients with refractory ventricular tachycardia. Now, presence of non-sustained VT among patients with hypertrophic cardiomyopathy tells us that the patient is likely to develop appropriate ICD discharges over a period of during follow-up. And if they have rapid non-sustained VT at rates more than 200 beats per minute, they are more likely to receive appropriate ICD shocks. If they have longer than 7 or 8 beats, again, that seems to indicate that in future patients are likely to develop recurrent ICD shocks. Now, when we evaluate patients with hypertrophic cardiomyopathy, a detailed history in terms of what triggers the ICD shocks or ventricular tachycardia is important. Because in several young patients who are athletic, the ventricular events, arrhythmias, are triggered by physical activity. And that will give us some insight into how to give medical therapy or beta blocker just before a physical activity is visible. This is a paper from Dr. Barry Maron's group, which looked at the hourly distribution of appropriate ICD intervention. They kind of plotted this and realized that in over 60% of patients, the ICD discharges seem to occur in mid-afternoon, probably in the postprandial state. So it's prudent, if you know this pattern, you can probably give a good dose of a short-acting beta blocker or something prior to the lunch or just around. The other simple condition which can be treated is obstructive sleep apnea. Obstructive sleep apnea in patients with hypertrophic cardiomyopathy has a significant impact in terms of, as the obstructive sleep apnea, there seems to be a dose-response relationship. As it becomes more and more severe, there is a greater and greater frequency of ventricular ectopy among patients with hypertrophic cardiomyopathy. This is an elegant, very illustrative case which was presented from Japan, which looked at refractory VTs in patients, several short-running non-sustained VTs in ICD, treated initially with sotalol, carvedilol, maximum doses increased, and then finally patient was given a CPAP, and you can see a dramatic decline in the frequency of ventricular arrhythmia. So it's extremely important to evaluate the patient as a whole rather than just looking at device or the drug alone, because these are simple comorbidities which can be addressed, and it matters a lot in terms of the patient's well-being. And secondly, all of us realize that shocks, even though they may be life-saving, they are very unpleasant. The good news is, in a vast majority, out of 349 episodes of fast ventricular VT, where the rhythm was more than 180 beats per minute, almost 264, more than 60% of them could be terminated by ATP, and even fast VTs can be managed by ATP among patients with hypertrophic cardiomyopathy. And the important thing is, especially in young patients, to program the device appropriately so that they don't receive inappropriate therapies from the IC. This is a 38-year-old gentleman from our own device clinic, non-obstructive HCM with significant scarring, primary prevention ICD, but for some reason he went home with free zone programming and received multiple shocks in 6 months. When he came back, all that we realized was he was programmed for a VT at 130 beats per minute, which was inappropriate. In all these patients for primary prevention ICD, please try to program them as a single zone device, prolonged detection zones, and switch on the SVT discrimination algorithms. They are quite robust in preventing inappropriate shocks. So single zone device, prolonged detection zones, and the discriminators for SVT should be turned on among these patients. So what do you do despite giving the initial beta blocker and other drugs? Patients have recurrent or refractory VT. The important thing is to identify the substrate, whether it's mid-myocardial obstruction with apical aneurysm or with this non-obstructive or its dilated phase. Appropriate choice of antiarrhythmic therapy. This is always the background of beta blocker therapy is mandatory. As long as there's no contraindication, they should all receive beta blockade. We uptitrate the beta blocker and have an atrial pacing so that pacing is not a limitation to uptitrate the beta blocker. I'll briefly talk about the role of radiofrequency ablation and stellate ganglionectomy and needle catheter ablation. So when you have a patient with recurrent non-sustained VT or VT with appropriate shocks, it's important to identify the triggers. Is it happening during exertion? During sleep, if it is happening, you need to rule out obstructive sleep apnea. When the patient wakes up, if you find that there are recurrent discharges, probably a long-acting beta blocker at night may solve the problem. LV apical aneurysms, if it is there, you need to again get further imaging to identify and consider catheter ablation for these patients. Uptitration of beta blocker. There is some data to suggest, not necessarily from hypertrophic cardiomyopathy, but other forms of VT storms. Among the beta blocker, propranolol is superior in terms of reducing the episodes of VT and VF storms. And even though it's not directly published in HCM, we try to switch to propranolol in some of these patients. In younger patients, this combination of sotalol and propranolol is used. If it fails, we continue the beta blocker but add amiodarone. If it's still refractory, add mexiltine to these patients. Among younger patients with significant obstruction who haven't undergone surgery, diazopyramide is an extremely useful option, both to control the arrhythmia as well as relieve the obstruction. This is a patient with a 56-year-old gentleman with dilated phase of hypertrophic cardiomyopathy, EF of 25%, incessant VT and heart failure. You find that what you're seeing this is an RAO, significant septal scar. What you're seeing in this colored area is all scarring of the endocardium. And you can see it in left anterior oblique. This is septum. This is the posterolateral wall. There are areas of low voltage and abnormal electrograms in the septum. After successfully targeting these areas, he becomes non-inducible. This is another patient. Here, you had a patient with VT storm, couldn't be controlled with several drugs. However, predominant substrate was in the epicardium, in the posterolateral area of the epicardial surface of the ventricle, who had low voltages, abnormal electrograms, and this patient was successfully ablated. What is important is in these patients present with recurrent and insustained, recurrent ventricular tachycardia, post-ablation, the ventricular function significantly improved. Another gentleman with hypertrophic cardiomyopathy, recurrent VT, you can see the sinus rhythm and VT. And whenever you see this kind of similar morphology between sinus and VT, you need to consider that this patient may have a re-entry within the bundle branches. This is extremely important because in our experience, a small proportion of patients with hypertrophic cardiomyopathy have bundle branch re-entry, and that can be easily ablated. You can see this patient here pacing the left ventricle. As we pace, the delay from left ventricle to right ventricle is huge. In sinus rhythm, it becomes more or less fused. What we mean is here, the impulse comes down the right bundle, turns transeptally back into the left bundle, and sets up a re-entry within the bundle branch. It's important to recognize this because it can coexist along with myocardial re-entry, and you may have to target this for successful ablation. This is an elegant publication which looked at the role of apical aneurysms as a cause of VT. Imaging, you can see a gadolinium enhancement, and you can see a contrast, echo with contrast, showing that there is an aneurysm-like outpouching, and they are responsible for recurrent VT requiring successful catheter ablation can be performed because this is a localized area for catheter ablation. Often you may have to go epicardially to take care of this substrate. This is our experience of catheter ablation of VT in patients with hypertrophic cardiomyopathy, 8 patients, and most of them we needed to go either endocardial or epicardial substrate. In 2 of them, a bundle branch re-entrant VT was induced and successfully ablated. The results of catheter ablation is modest, that once you get rid of all the VTs in hypertrophic cardiomyopathy, this is over a period of 3 years, you can find that you can offer VT-free interval in almost 75% of these patients. This is another patient who had recurrent VT, prior ablation performed, was doing well for a while, and then about 2 years later, he came with recurrent VT VF throughout almost every day, multiple episodes of VF and shocks. And you can find in this patient, all these episodes were happening, most of them when he woke up in the morning and had a breakfast. We realized that this could be sympathetically mediated, and we couldn't escalate his beta blocker. And this was sympathectomy that was performed. And post-sympathectomy, you can find there is no VT over the next 1 or 2 months. This patient is doing well about 5 years after we saw the patient was free of VT. The major problem in catheter ablation of VT is the hypertrophied septum and hypertrophied ventricle. So the septal substrate is quite daunting in these patients, and some of them, the substrate for VT may be intramural. It's neither endocardial nor epicardial. You can see an intramural focus for re-entry. So the current strategy is to go both from the right ventricle and the left ventricle and do a bipolar sandwich ablation between the two, or from endocardium and epicardium and a sandwich. Even this doesn't work always, and then there is a development of having a needle catheter through which you can advance a needle directly into the myocardium and inject alcohol. First, you localize where the VT is coming from. You can record the electrogram and make sure that that is the site you want to ablate. Inject a little cold saline there to see whether the VT terminates. If it terminates, that is the target, and you can take absolute alcohol and inject it to this space to get rid of intramural VT. So in summary, when you have patients with recurrent non-sustained VT and ventricular tachycardia and hypertrophic cardiomyopathy, after an ICD, it's important to go through the history, identify the triggers, identify whether it's an exertional VT or whether it happens during sleep, whether there's a left ventricular apical aneurysm. So depending on what you find, you may kind of dose these patients with a short-acting beta blocker before exertion or in the night, look for sleep apnea, correct all these correctable factors. The mainstay of therapy will be beta blocker, and the first line choice will be beta blocker with sotalol, because you will know this efficacy and long-term safety will not be a problem with sotalol if the patient gets control. However, please remember, sotalol has reverse use dependence, and it's better to have a atrial-based pacing and make sure you avoid bradycardia during night to maintain the atrial rate above 60 throughout the night. If this fails, the second line drug is amiodarone with or without Mexalti. In younger patients with obstruction, diazopyramide is a good choice, but we need to watch for QT prolongation. If the BP continues and is recurrent and patient is having recurrent ICD shocks, you need to consider radiofrequency ablation, which can be done with modest success. In our experience, it works in about 75% of the cases. About 25% of them may have recurrence and a second procedure may be. For patients where from the history and the device log, you find that it's predominantly happening early morning when the patient wakes up or during an episode of sympathetic surge, we should offer stellate ganglionectomy. Bipolar ablation and needle ablation are newer options which are helpful in patients with refractory mid-myocardial VT, and we should be able to achieve a higher success rate with all these tools. Thank you very much for patient listening.
With that, we come to the end of a very interesting session, and we'll just kick off the live Q&A. I would invite Professor Mohanan, sir, to start off the proceedings, please.
Let me shoot the couple of questions to Dr. Ethan. Dr. Ethan, you said about the LG, the importance of it as a marker of the SCD. Two queries on that. What about the reproducibility of the LGV quantification? Now, you have various vendors, various softwares. That's one. Number two is we also know the LG distribution is many a time heterogeneous. So how will you go about it? These are the two questions that I'll pass.
Yeah, those are appropriate questions. One of the downfalls of LG quantification is that there are variable techniques to quantify LGE. The technique that we used in the Raymond Chan paper was both 6 standard deviation, which basically means you take an area of myocardium that is well nulled, and you use that as a reference region, and then anything that's 6 standard deviations away from that is quantified as LGE. The problem with that is obviously the myocardium in HCM is not necessarily normal. In fact, we know that the structure, even in areas that are not hypertrophied, is abnormal. We also, in that paper, with similar results, used manual thresholding, which is where you look for areas of bright. So there are definitely limitations with regards to LG quantification, and perhaps one of the biggest referrals for us right now in terms of LGE is where people are getting really high quantification of LGE, and when you look at the MRI, there isn't that much LGE actually visible, and they're sent to us as to this patient really needed ICD just based on the LGE, and we re-quantify, and what was a lot actually when we quantify it is a little. Realize that what we're talking about is visible high signal intensity LGE on MRI, and basically you should be able to see it easily, and it should be a lot. If you're having a hard time seeing a large amount of LGE, then the quantification is inaccurate. So that's the way we did it. We're working with a group at Beth Israel in terms of trying to better automate it with machine learning to hopefully take out some of those different difficulties in quantification.
Okay.
There are, hello, Dr. Mohanan, there are a couple of questions actually for Sam, but I think Narasimhan can take them. That which patients who are undergoing a myectomy should also undergo a maze procedure? And the second is which patients of HCM would do better with, ablation, pulmonary vein isolation?
Is Narasimhan around?
We strongly recommend that they stop with myomectomy for the simple reason when you do a maze, the intra-atrial conduction delay increases. So unlike patients with ischemic heart disease or rheumatic heart disease, you find that patients with HCM, you tend to produce more harm when we try to do a maze procedure. So we avoid maze procedure and just confine to myomectomy alone.
But then what about doing a pulmonary vein, surgical pulmonary vein isolation, not a maze, when they are undergoing a myectomy?
Okay, that's a very, very good question. In fact, this was attempted by Japanese workers where they do a cryo around the pulmonary vein, nothing more, they come out. If during myomectomy you do a mitral valve replacement, they do a isthmus line so that there is no limitation for the EP to reach that area later on. So while mapping HCM, you can look at the LG different areas of the atrium, and that is where to just isolate the PVs alone.
Okay, which patients would be suitable for ablation in HCM? Because we know the results are not as good as, obviously not as good as a normal hearts with paroxysmal AFib. So which patients of HCM will you be, more gung-ho about taking for ablation?
So if you don't have a large left atrium and the left atrial appendage velocities are preserved, so that means this patient doesn't have extensive scarring of the left atrium, and you can probably consider ablation. Second thing is patient with eccentric mitral regurgitation, wherever the MR jet hits the posterior wall, there is a dense scar. So that area becomes difficult to ablate. We take all these things before we consider. So my threshold for ablation is very, very high. When you kind of evaluate the patient in detail, if it's chronic persistent atrial fibrillation, I know there's some echoing here, I don't know. So chronic persistent atrial fibrillation where the success rate is going to be less, I would do a brief cardioversion. If the patient is not able to maintain sinus rhythm, we go for a CRT and a AV junction ablation.
There are some mixed signals regarding sotalol in hypertrophic cardiomyopathy. In a patient without an ICD, would you use sotalol in HCM?
Yeah, we can use. The advantage of sotalol is you know whether it's working or not within the first 3 or 4 days, at least in terms of side effects. So on the third day, if the QT is normal, we do a Holter, and the night there is not too much of a bradycardia, we are fine to discharge the patient. So we tend to use sotalol as the first line in a younger patient where you don't want him to use amiodarone as the first choice.
My question is about, you've given disopyramide, which has, relieved the symptoms and relieved the obstruction. But now from yesterday's symposium also, we got from Dr. Barry Maran's talk that, obstruction itself reduces the long-term survival. So if there is a decent response to disopyramide, but there is still gross hypertrophy of the outflow region, should one still go for surgery if there is a good response to disopyramide?
So if the patient improves significantly and you do an MR, this is what we have been doing. If MR shows evidence of significant LGE and the patient has a lot of non-sustained VT despite reduction in the gradient, then we offer an ICD.
The obstructive sleep apnea, both you and Sam spoke about it. Now, is it necessary that if OSA is a trigger, the arrhythmia should occur in the sleeping hours?
Not necessarily. I'm glad you brought up this question because obstructive sleep apnea, you need to look at what is known as surrogate for adrenergic activity. And these patients will have episodes next day morning because their adrenergic drive is high. So constantly through the night, they are doing a Valsalva throughout the night, plus desaturation. This has a very bad effect in especially HCM. If you ask one disease which rapidly worsens hemodynamically, that is HCM, and OSA is a bad combination.
I have one question from the audience. I have one question from the audience. So to Dr. Ethan, how many patients with a septal knob have an HCM mutation? Many older patients have this feature. So should we do a CMR for all such patients? Dr. Ethan.
Yeah, so the question is, twofold. One is that genetic mutations in older patients in general are less commonly seen. So negative genetic testing might not help you here. I think the other question is, you see a septal, quote unquote, knob, is that really HCM? And the answer to that question is based really on a number of different things. One, how thick is the septum in that area? What is their background medical history? Do they have hypertension? So if you see a septal knob over 17 millimeters, absence of hypertension, despite the fact that they're an elderly individual, that is still likely HCM. In contrast, if you see a septal knob that's 14, 15 millimeters in someone with longstanding hypertension, it's unlikely phenotypic HCM.
Right, thank you.
Ajay, sorry to interrupt you. Dr. Ajay, we don't want him to be keeping ma'am. Ajay, do you have the CMR data on your idiopathic restrictive cardiomyopathies, Ajay?
We have a very limited CMR data in the sense that we have a relatively small cohort of around 7 patients. So out of these 7, 6 of them had very significant LGE. And even in a cohort, like I just showed, that in a family, 2 out of 3 had sudden death. So sudden death is, apart from heart failure, even sudden death is a major problem in idiopathic restrictive cardiomyopathy.
I have a question to Dr. Ajay as well as Dr. Ethan. So in cases where, we've seen a couple of cases with AV blocks and HCM, and you said in those patients you need to suspect desminopathy. In those cases, is there any typical appearance of scar, or is there any way MRI can help say that it could be desminopathy? Is there any difference in the way the scar appears?
So it can be desminopathy, but also PRAKG2, which is another thing when you should suspect when you see AV block, which you guys have a lot more experience than we do in analysis of. I believe Hisham presented your experience with that yesterday. It's very patchy. It tends to be, though, in general, very patchy LG in the septum, the few cases that I've seen. But again, we have not seen much of that in our cohort.
Thank you, Ethan. I think for want of time, I think we'll conclude this session. And thank you to all the speakers for their fantastic talks. Dr. Muthaiya, can we go on to the next session, please?
That was a great session. So moving on to the next session, we have 3 great talks, and it's chaired by an eminent faculty panel. Next slide. Chairing this session will be Dr. R. Krishnakumar. He's the clinical professor and head of Department of Pediatric Cardiology at AMRITA Institute. Dr. S. Harikrishnan, professor of cardiology at Sri Chitra Institute of Medical Sciences and Technology. And Dr. K.R. Balakrishnan, chairman of Cardiac Sciences and director of the Institute of Heart, Lung and Transplant at MGM Healthcare. So I'll give it over to Dr. Krishna Kumar sir to introduce our next speaker.
Good evening and good morning, depending on where you are. This is an incredibly interesting symposium on hypertrophic cardiomyopathy. It's a disease diverse and intriguing and enigmatic enough to justify a full symposium. And we have an host. Yeah, we have an extremely eminent speaker who's a close friend, Dr. Sheshadri Balaji, who is also a visiting professor at AMRITA Institute of Medical Sciences, and we collaborate very closely on a host of issues specifically relating to pediatric electrophysiology. And we have written a number of papers together, both within and outside electrophysiology. Now, he has a special interest in cardiomyopathy, and I think he was in many ways responsible for igniting this interest in childhood cardiomyopathy at our center, and that has translated into a fair amount of very interesting research. With that, I would not take too much more time, and I would hand this forum over to Dr. Balaji for his talk, which I'm sure is going to be very illuminating and interesting.
Good morning, everybody, and good evening to everybody in Asia. I want to thank the organizers, and in fact, it has been a delight to be part and parcel of organizing this meeting in some small way. Two disclosures. One, I have a research grant from Medtronic to study hypertrophic cardiomyopathy in children. And secondly, I am a proud member and the current president of the PACES, which is the Pediatric and Congenital Electrophysiology Society. And therefore, it's my honor to give this talk on hypertrophic cardiomyopathy in children. The overview of my talk is here. First of all, I'll be talking about infants, followed by older kids with hypertrophic cardiomyopathy. In infants, I'll be stressing the importance of inborn errors of metabolism and malformation syndromes, etc. We'll then talk about modes of presentation, talk about heart failure and the treatment for heart failure, a little bit about exercise restriction issues, and then the bulk of the talk is going to be about sudden death in childhood. Finishing up with some issues about sudden death in the family and the implications that has for children. So let's get started. Hypertrophic cardiomyopathy in infants is often part of a multi-system disease. These children can have rasopathies like Noonan syndrome, etc., and also inborn errors of metabolism, such as glycogen storage diseases like Pompe's or mitochondrial diseases. It is very important to look for multi-system disease in infants who present with unexplained hypertrophy. A metabolic panel can help. Renal failure, if present, can also help and point towards a multi-system disease. Occasionally, we come across a newborn who has significant hypertrophy, and this is due to what is known as infants of diabetic mothers. And so it is important to make sure that the child does not have a diabetic mother, because in those patients, hypertrophic features will resolve with time. Anyway, idiopathic and sarcomeric hypertrophic cardiomyopathy also occurs occasionally in children, in infants, and has to be borne in mind. So genetic testing these days is important even for infants. For example, if you take this study from the Pediatric Cardiomyopathy Registry, the Pediatric Cardiomyopathy Registry is a large registry, or started around 1990. Some of the leading experts in the field got together and started this registry. And this is one of their reports that came out in 2013 that looked at only the hypertrophic cardiomyopathy part of that registry, because that registry looked at all forms of cardiomyopathy. And as you can see here, they were able to collect over 1,000 patients with hypertrophic cardiomyopathy, but only 407 of them had what we call sarcomeric hypertrophic cardiomyopathy, or what they called idiopathic hypertrophic cardiomyopathy. The others had things like inborn errors of metabolism, or multi-system disorders, malformation syndromes, etc. When you looked at the subclassifications, the idiopathic or the sarcomeric group had the best outcome. Those with inborn errors of metabolism or malformation syndromes, etc., had the worst outcome. In this study, there were so few sudden deaths that they could not stratify for sudden death, but there were significant amounts of death and transplantations due to heart failure, that they could classify for that. So one of the findings, as you can see from this Kaplan-Meier curve, is that if the hypertrophic cardiomyopathy was diagnosed at a older age, shown in red in the top panel, they had a much better prognosis, and freedom from death or transplantation was much better in them than in those diagnosed at a younger age, or those with concomitant presence of a malformation syndrome. In the lower panel, you see three categories: one with inborn errors of metabolism, one with hypertrophic cardiomyopathy with additional features of restrictive cardiomyopathy shown in red, and in the green, hypertrophic cardiomyopathy with features of dilated cardiomyopathy as well. This is an earlier era paper and a cohort, and not much genetic testing in the study. But as you can see, even looking at the structural features, they could stratify fairly well. So in smaller children, the importance of inborn errors of metabolism has to be borne in mind, malformation syndromes, etc. And these children have a high risk of developing heart failure and going on to either die or need a heart transplantation. In older kids or teenagers with hypertrophic cardiomyopathy, which is a huge group that we deal with day in, day out, the hypertrophic cardiomyopathy is mostly sarcomeric or idiopathic. These patients, as shown by the cardiomyopathy registry, have a much better prognosis than infants. But now we are starting to come into the risk for sudden death, not just heart failure death. In fact, as I will show, heart failure death is pretty rare in this group. This is, however, is a poorly studied group. Their modes of presentation vary significantly. They vary all the way from incidental finding, either found during a family screening or some other form of screening, a primary care physician hears a murmur, etc., or all the way to the most severity, which is sudden death or near-miss sudden death. If symptoms are present at the time of presentation, it is a bad prognostic sign, as I will show you later. The ECG can be normal in about 10% of these patients, even with a phenotype. So sometimes the hypertrophic cardiomyopathy features are very early or very mild, and so the ECG may not yet be abnormal. So the echocardiogram is the test to make the diagnosis in patients. If they are gene positive, but they do not yet have a phenotype on echocardiogram, then we generally see them at the time of presentation or whenever they first present to us. The family often has many questions, etc., that has to be dealt with. But then we really start seeing these patients starting from the age of 10 every year until they are 18, and then they're usually transferred to adult cardiology, where they are screened every 3 to 5 years or until they start showing signs of a phenotype. Heart failure in kids is actually very rare, except in the infant period. Most often seen in patients with severe left ventricular hypertrophy or severe diastolic dysfunction or severe left ventricular outflow tract obstruction. There are certain broad principles to management of heart failure in children. First of all, fluid management is very important. These patients have a non-compliant ventricle, and therefore they need a high preload. They need a high filling pressure in order to produce a decent cardiac output. Anything that reduces the preload, such as diuretics or illnesses where the fluid intake goes down or they're having vomiting, etc., can be a significant negative problem in terms of reducing the cardiac output. However, it must also be borne in mind that giving them too much fluid can be a problem because of the lack of compliance. They can back up into their lungs and develop pulmonary edema. Another important principle is to avoid inotropes like digoxin, especially in those with severe left ventricular outflow tract obstruction, because that is going to make it worse. We generally use beta blockers or calcium channel blockers, typically only in patients with symptoms, rarely in patients in whom we think they are borderline or they have severe hypertrophy and we are worried that they may be minimizing their symptoms, etc. And usually the things we are aiming for is a lowering of the resting heart rate to produce a better filling time, etc. in these patients. Myectomy is used in select patients with left ventricular outflow tract obstruction in specialized centers, and I will not be going into the aspects of myectomy in this talk. What about exercise restriction? This is an area that's actually poorly understood, believe it or not. There are studies that are in progress, which will hopefully clarify the situation in the next few years. But one of the important principles in these patients is to avoid obesity. We showed recently that obesity can be a bad prognostic sign in these patients. And therefore, it is very important not to tell them to be completely off of all activities. It's important for them to continue to do some activity, However, they should avoid competitive sports based on current guidelines, but we generally allow recreational and low-intensity sports in these patients. Weightlifting is discouraged, especially if it means holding their breath while they're lifting their weight. The weight is so heavy that they have to hold their breath. Generally, that means that their afterload is increased, their blood pressure is high, and therefore that is a stimulus for hypertrophy and not a good idea. Smaller weights with multiple repetitions are okay because generally people don't have to pause their breathing in order to do it. The presence of a defibrillator, an automatic external defibrillator, if possible at the time of sports, whether it is practice or whether it is competitive sports, and even if there is a patient who has a defibrillator, has an implanted defibrillator, having a backup automatic external defibrillator on site is a very important factor. And if at all possible, this should be present.
That is for me to speak.
Now, coming to the bulk of my talk, which is about sudden cardiac death, as you know, whenever a patient is diagnosed with hypertrophic cardiomyopathy, one of the first questions that immediately arises is, what is their risk for sudden cardiac death? Unfortunately, this is not yet fully understood in children. I will show you a few papers showing some progress. However, there are many, many adult papers starting at around the age of 20 years of age. As I already showed you, there's been the pediatric cardiomyopathy registry studies, both in the PCM registry in America, and then there's been a very large Australian registry. But most of these registries in children have showed a low incidence of sudden cardiac death because most of their patients typically started off in infancy or at a very young age. So basically now there is a gap in the literature between the age of 10 and 20 years of age. What about defibrillators? Once you think there is a risk of sudden death, you place a defibrillator. And as the slide shows, these are all my patients, starting from a patient with a defibrillator placed at the age of 3 months. One at 5 years is an epicardial defibrillator. These both are epicardial defibrillators. There is a pace sense lead on the right ventricle placed through a xiphoid incision. In this patient, we have used a standard single coil lead in the pericardium behind the heart. This is a standard transvenous placement in a 7-year-old child. And this is a subcutaneous defibrillator in an older child. So defibrillators can be placed now at almost any age, but who to place it in is the question. If a patient presents with sudden cardiac death or near-miss sudden death, that is a slam dunk, we can justify placing it. But primary prevention is the problem, and how to predict those asymptomatic patients who have not yet had a major symptom, how to place a defibrillator in them. And therefore, risk stratification becomes the real key to management in children. This study, which Dr. Marin published in Circulation in 2000, for example, tells you that when you look at the mode of death in hypertrophic cardiomyopathy-related death in patients, you see that in the 5 to 15-year age group, pretty much everybody died of sudden cardiac death. When you get into the slightly older period, you start to see some heart failure-related deaths, and heart failure-related death gets bigger as time goes by. But in the very small children, in the teenagers, sudden death is pretty much the only way they die, and therefore it's very important to predict it and prevent it. We know these adult risk factors from all these adult studies. There's been a number of talks about this, so I'm not going to belabor this point, but the question is, what about children? In fact, as you've probably seen already in this meeting, this is a very important paper that came out of Europe, coordinated out of London by Dr. Elliott and colleagues, showing that they could risk stratify and create a risk prediction model in these children. And in the European Society of Cardiology website, as you know, you can go in and do a risk prediction by entering the data. However, there is a clear disclaimer in there, which is that this is not applicable to children less than 16 years of age. So currently, we don't have guidelines or risk calculators available for children or adolescents, but as I will show you, there has been some significant progress. Started off with this paper from Dr. Marin and his multi-center group published in JACC in 2013, where they were able to collect 224 children, all with defibrillators, and they looked at various factors present in these children to see which ones were associated with appropriate ICD shocks. And they showed that extreme left ventricular hypertrophy, which is an important finding that Dr. Marin has emphasized for many, many years now, was a very important association with appropriate interventions. This paper then came out in 2018 from the Italian group, from Dr. Olivotto's group, showing that in pediatric onset hypertrophic cardiomyopathy, they looked at age-specific risk factors for lethal arrhythmic events, basically ventricular tachycardia and ventricular fibrillation. They had 100 kids less than 16, and 24 of them had VT or VF. There were two predictors, which is symptoms at rest and the presence of troponin mutations. And when they looked at the adult risk factors to see if they were predictive for sudden death, they found that it was very poorly predictive. This is a study that I was able to coordinate through my colleagues at PACES, a large multi-center study, which looked at 446 children aged less than 20 years of age, all with a defibrillator. 22% of whom had a secondary prevention defibrillator and 78% had a primary prevention defibrillator. Again, we were able to show that adult risk factors were not predictive of sudden death. And the main predictors were left ventricular posterior wall thickness, which was a significant association with sudden cardiac death. And interestingly, left ventricular outflow tract obstruction, severe left ventricular outflow tract obstruction presence was actually seemed to be protective in that those patients had a lower risk of sudden cardiac death. The London group from Juan Kasky from Great Ormond Street and Gabriel Norish were able to collect a large cohort of patients, and they have actually now developed a risk prediction model. So progress is happening really fast as we speak. They were able to collect over 1,000 patients with hypertrophic cardiomyopathy in children. They derived a model to predict sudden cardiac death within the next 5 years from the time of diagnosis, with an excellent predictive accuracy and a C statistic of 0.69, which is excellent, almost as close as what the adults have achieved. They were able to show that for every 10 defibrillators placed in the high-risk group, which is defined as a risk of greater than 6% over 5 years, at least one patient was able to be saved. Seema Mittal from Toronto and her colleague Anastasia Miron published this year, looking at a validated model for sudden cardiac death in children with hypertrophic cardiomyopathy. They were able to collect 572 patients, and they had a slightly higher risk C statistic of 0.71. Predictors for death, sudden death in this group were listed here: age, diagnosis, non-sustained ventricular tachycardia, presence of syncope, and then the Z values, which is the number of standard deviations away from the mean of the septal thickness, the posterior wall thickness, the left atrial diameter. Again, they were able to show an inverse relationship with left ventricular outflow tract obstruction, confirming our findings, and presence of a pathogenic variant. Family history was not related, and as shown by their C statistic, they were able to improve the prediction accuracy. So one last thing I want to mention about sudden death. If a sudden death in a relatively young person, less than age 35, maybe even less than age 50, deserves an autopsy, it is very important not to use the right language and not to use the word massive heart attack. I see this among a lot of people, especially in India. My medical school group in India, we have a WhatsApp group, and people frequently write, so-and-so young person died of a massive heart attack. And I have to go in and correct them and say, not a matter, don't use the word massive heart attack, use the word cardiac arrest, because these patients needed a autopsy to make sure that the index patient did not die of a cardiomyopathy like hypertrophic cardiomyopathy. Diagnosing hypertrophic cardiomyopathy in the index case can save their children, can save their siblings and other people in the family. And it is very important not to let a sudden death go in vain. If a person dies and we don't know why they died, it is very important to advocate for an autopsy in this family. So let me come to my conclusions. Infants with hypertrophic cardiomyopathy often have other syndromes, inborn errors of metabolism or malformation syndromes, and they have a high mortality, mainly from heart failure death, or they need transplantation. Sarcomeric HCM is more often diagnosed in older children, and sudden cardiac death is a risk mainly in older children and adolescents with sarcomeric hypertrophic cardiomyopathy. Risk factors are different in children and teenagers compared to adults. Common adult risk factors do not seem to be as predictive in children. As you have seen, and as I have showed you, there has been huge progress on risk stratification in kids in the past 2 years. And I believe further progress will be made as we establish a more robust international registry. There are many unanswered questions in children, and there is a huge need for prospective studies. These measurements that we derive on the echo and MRI and so forth are dynamic And in children, they are changing all the time, and therefore they need to be dynamic measures rather than static measures. And as I have mentioned already, there is need for a HCM registry, and my society is very interested in collaborating with anybody interested in this field. Something we are taught on the first day of pediatric residency, which is children are not little adults, holds completely true for hypertrophic cardiomyopathy. Thank you very much.
Good evening, everyone. For the last 3 decades, we didn't have any newer drugs in the therapeutic armamentarium. This year, we had 2 major studies published, the Explorer HCM and the Maverick HCM, one on obstructive, the other on non-obstructive HCM, which showed a great interest and some hope of a new drug, the mavacamten, the myosin inhibitor, which is very promising in the treatment of hypertrophic cardiomyopathy. To speak on this, we have none other than Dr. Jacopo Oliver, who was the principal investigator of the Explorer HCM study. Welcome, Dr. Oliver, for his talk on the molecule and study.
Thank you. Thank you for having me. Dear friends, ladies and gentlemen, my name is Jacopo Oliver, and I work at the Cardiomyopathy unit in Florence, Italy. It is my great honor and pleasure to be here with you, although God only knows I would be there in person. I would like to thank Dr. Hisham and my friends who have organized this symposium. My role here is to talk about novel therapeutic reactions and recently therapies. These are my disclosures. And you have probably heard from other speakers, you will hear again how complex hypertrophic cardiomyopathy is, and it is almost incredible that single nucleotide substitution in sarcomere protein genes can give rise to such a complex microscopic and clinical phenotype with such diversity and such complexities in clinical manifestations and treatment. One of the major components of this disease is hypercontractility. Maybe you see this better if you forget about hypertrophy for a while and consider the cavity. Just take out the muscle and look at the function here as shown here in this CT image. You can see that definitely this is a disease of hypercontraction. And why is this? Well, we have understood most of these paradigms because of mutations in beta-myosin. Beta-myosin is not the most common gene. The most common gene involved in HCM is protein C, but it definitely, myosin is the best understood, the most immediately intelligible of these genes. And we know that mutations in the hinge, in the lever sort of area of the molecule, which is very sensitive, gives rise to HCM, and the more the sensitive the position, the more severe the phenotype will be. The reason for this is that the activated myosin, this is a natural doping of the myosin. The myosin mutation causes an enhanced activation of the protein, which rather than sitting in a super relaxed fashion like most myosins do during cardiac cycles, will be statistically more often activated and therefore involved in contraction much more than it should be. So the number of resting myosin heads at each contraction is actually less than it should be. We know that most of the myosin heads are actually in a resting position or even in a super relaxed position during contraction, so that the heart may have a large reserve of energy and contraction to keep working for a lifespan. And these hearts are all like Lamborghinis, Ferraris. They are naturally doped, and therefore too many myosin heads are activated at one time. The consequences of this, besides creating compensatory hypertrophy, or at least this is what we think it does, is also that in some patients will make the situation unsustainable because of excessive energy spending and loss of cardiac efficiency, so that a number of patients will over the years develop adverse remodeling and evolve towards the end stage phase of disease. And we do know that this is a time-sensitive disease. Many of the complications, this is data from the shared registry, which is now the probably largest registry in HCM, involving a number of centers in the US, Europe, Australia, and elsewhere, you can see that with age, the burden of disease becomes evident. If you just look at the upper left panel, this is the probability of developing something bad related to HCM, depending on the age of diagnosis. The earlier you are diagnosed, the more likely you have to have some adverse events, including atrial fibrillation, heart failure, or arrhythmic events. And the later you are diagnosed, the less. But in any case, you can see that this is a time increasing burden of disease. And the way I picture this is like imagining Napoleon trying to conquer Russia. So this is a genetic, ambitious project, which builds a phenotype that is too hard to sustain. And when winter comes, then the non-sustainability of the system forces a retreat. And what does winter look like in HCM? This is an end-stage patient. You can see the hypercontractility has gone. This is definitely hypocontractile, restrictive evolution. And if you look at these hearts, most of which required explantation and transplantation, you would see that up to or over 40% of the myocardium is replaced by fibrosis. And this is due to the fact that such energy expenditure is not sustainable for the system. So the concept arose that it would be very nice to have molecules that target specifically the hyperactivated myosin molecules by inhibiting their excessive affinity for actin, and therefore sort of normalize, counter this situation. And two such agents exist right now. Mavacamten is the first in class and is the agent that has been used in Explorer, and the other agent is called CK-274 and is still in phase 2 implementation, hopefully soon in a phase 3 study as well. And this is what these agents do. On the left, you can see normal myosins, and on the right, it's the myosins treated with these agents. You can see that they are moving much more slowly. So in a way, they are sort of made to be lazier. But in fact, it's normalizing the situation. It's not making it worse. It's actually normalizing the situation. And the proof of concept lies in animal studies, which show that mavacamten, for example, in this very, very nice study published almost 4 years ago now, not only suppresses or prevents hypertrophy, but it can also normalize, for example, disarray. And so does a lot of very nice things in the animal. Of course, mice are not men, and a lot of things have worked in the mouse that have not worked in man. So it is quite important to have proof in patients. So where would one start in testing a drug like this, something that is a negative inotrope that sort of tends to normalize contraction? Of course, it would be nice to have it in all patients with HCM. However, it is difficult to test patients with non-obstructive HCM, for example, because they're so heterogeneous. So the logical thing was felt to start by testing it on patients with obstructive hypertrophic cardiomyopathy and symptoms related to obstruction. As you know, this is one of the most visible features of the disease. It is a condition that often requires surgery or hospitalization because control of symptoms and gradients with existing drugs is often not feasible in a satisfactory manner. Well, by enrolling patients with severe obstruction and symptoms in hypertrophic cardiomyopathy, a phase 2 study was performed called PIONEER HCM. This was a US-only study, and what PIONEER showed is that very successfully the drug could reduce both the gradients at rest, which is the blue lines, as well as gradients at rest. The two cohorts used different doses of the drug. And in cohort B, lower regimens were used, but beta blockers were allowed. And you can see that in both studies, but particularly in cohort 1, so with a higher dose, the reduction of the gradient was really striking, and accordingly, symptoms improved and a number of quality of life indicators improved as well. This is what the drug does. So it's a slow-acting drug. It takes about 4 weeks, about a month, to display its actions. You can see that the reduction in ejection fraction, I'm sorry that this video is not all of them are running, but reduction in ejection fraction is not very evident, but gradually you can see a reduction in SAM as well as a reduction in gradients with Valsalva and resting as well. And what is very reassuring is that the levels of anti-proBNP also go nicely down accordingly, so that this implies that there is a real benefit to the hearts, to the myocardium, and not only a sort of an effect on the gradient, but also on heart stress. And of course, these patients felt a lot better. So based on this very successful story, a phase 3 study was very carefully designed. This took a long time to design, although the study is very straightforward. The study enrolled 250 patients with symptoms and obstruction. They had to have a gradient of at least 50 millimeters of mercury, either at rest or with exercise. They were randomized on a 1-to-1 basis to mavacamten and placebo, and had a 30-week treatment period with 2 titration phases based on pharmacokinetic levels of the drug. So plasma levels of the drug were used to titrate, as well as systolic function and gradient response. What was really difficult to come up with was a convincing primary endpoint. So these are the features, the background features of the baseline features of the patients enrolled. And you can see that these are, I would not go into detail for the sake of time, but these are really very much the patients that we see every day in the clinic with severe obstruction, late 50s in this case. Background therapy was allowed in the study. This is very important. So patients could be on beta blockers for the majority, most cases, or calcium channel blockers, non-dihydropyridine, of course, and that also was quite common. They had to have symptoms, and their VO2 was, of course, reduced at baseline. Their BNP was elevated.
We had some audio disturbances, so we're inviting Jacopo to deliver his talk live. I've requested him, and he has kindly agreed to do so. Jacopo, could you share your screen, please? We're ready to go.
Can you hear me?
Well, loud and clear, loud and clear.
Okay. I'm sorry about that. I don't know what the problem was, because on the YouTube, it was actually quite nicely ordered. I will not start from the beginning, just be too long and boring.
Yeah.
Thank you so much for having me, first of all, Hisham, and thank you for everybody. I'm really sorry about the technical inconvenience.
All right.
So I would just start by with the final part of the talk, which entails presentation of the Explorer HCM trial. So forget about the background. I hope you understood. But as you know, Explorer HCM was a phase 3 multi-center trial which enrolled 251 patients with hypertrophic obstructive HCM. They have to have a gradient of at least 50 mercury in rest condition or exercise. We're randomized by counting 2 periods, 2 titration phases, and then a 20 to 30 weeks of treatment. Washout and enrollment in a long-term extension trial was still ongoing. And these are the baseline features of the 251. You can see nice matching of most important features, definitely symptomatic, although I would emphasize that 3 were actually in class 2, so not in the research cohort where it's about 3 and only accorded class 2. Of course, atrial fibrillation was relatively planned and it was elevated. And let's go straight to the primary point. So primary endpoint was very difficult to design because on one hand, we have some very nice surrogate endpoints looking at gradients, as you have seen, Pioneer trial, looking at a number of markers, but the FDA, the regulatory bodies, as you know, require a point which has to be clinically viable. So it had to be something to do with objective documentation, patient's performance and symptoms. And therefore, we chose a combination of either a modest improvement in peak VO2 consumption at the end of treatment compared with baseline, associated with at least one NYHA class improvement, or alternatively, a greater improvement in peak VO2 of 3 millimeter per kilo per minute with no worsening in NYHA class. And well, the primary endpoint was achieved by 37% of mavacamten as opposed to 17% on placebo. The result was highly significant. And it's nice to see that also 1 out of 5 patients also hit both definitions of the primary endpoint, which means they were like also endpoints. But of course, this is not the criteria we would use to judge what we've used so far. So looking at the secondary points here is really important because they are more, there's what we usually use in clinical practice. For example, if you look at post-exercise gradient, there was a fall in 50 millimeters of mercury in the mavacamten group as opposed to 10 in the placebo group. Peak VO2 consumption improved about 1.4 millimeters compared to no change in the placebo group. And this is also important. 65% of patients in at least one NYHA class, as opposed to 30% in the placebo. And also the two lines here, which have to choose varying because they reflect in a global fashion well-being of patients. So what is really important to is, and they showed very clear improvement of about 9 points, which used in a heart failure setting would definitely be significant. And the final score, which was specifically developed for HCM, was improved. Negative means better, so it was much better. All these endpoints were hierarchies, meaning you could not assess the false positive and see they were all very highly statistically significant. So this slide summarizes the thing. As you see on the top left, you can see the fall in post-exercise gradient. Orange is the placebo, blue is the mavacamten arm, and you can see that most patients with a very small error bar fall beneath the 50 millimeter of mercury, which would sort of make one consider surgery, for example. The mean was 38 millimeter of mercury post-treatment. And if you go to the bottom panels, resting gradients, both rest and with Valsalva, fell very sharply and on average were below the actual definition of obstruction. So these patients were rendered non-obstructive at rest, the vast majority of the patients, as opposed to no change in the placebo group. And this was obtained at the cost of a very small reduction in ejection fraction. You can see the top right panel. First in class, you really want to be reassured that they are not harming the patient. And of course, it's nice to be fall in ejection fraction required, but this nice result is only 4% on average. And even more interested in a sort of a long-term perspective, you can see that if you examine the change in NT-proBNP, again, mavacamten is in blue, and in troponin I, which is released spontaneously in a number of patients with HCM, it's very reassuring to see how rapid and sustained the fall is in both of them, suggesting that this may actually relieve stress, ischemia, and promote long-term advantage in hemodynamic balance. Of course, this has to be seen, but very important. This is so consistent. The profile, again, this is so important to us and it remains important. We still need to know more about this drug and its safety profile. But in the study, there was virtually no difference with the placebo in terms of number of patients and number of events. Actually, if anything, serious adverse events occurred a little bit more frequently in the placebo group because atrial fibrillation was more common, presumably because the atria were stretched by the obstruction, whereas the treatment arm was not. There was only one sudden death which occurred in the placebo group. There were a number of patients, small number of patients who discontinued mavacamten because of a fall in ejection fraction below 15%, which was a sort of safety endpoint. All of these were 7 in total. They withdrew temporarily, they washed out, and then they resumed treatment and are now happily enrolled in the long-term extension trial. So this was a temporary thing with no long-term harm to the patients. Very recently at the American Heart, this was this week, there were two presentations. One was the CMR, so magnetic resonance sub-study of the Explorer was presented. This is still, has been literally published just now. It's published in Circulation this week. The interesting point is, I don't have time to go into the details, but there is a reduction in mass, in LV mass, which was the primary endpoint. Difficult to explain why in such a short time, but it's still interesting as an exploratory endpoint. And also was reviewed. What is probably important in terms of patient symptoms and long-term outcome, the left atrial volume is very clearly. The second presented at a subset from Explorer was the O parameters were fall in LV mass index as opposed to placebo. I don't really like echo mass by echo, so I don't really at this left atrial volume index, which was clearly reduced as compared to placebo, and the systolic parameters which improved markedly in terms of lateral and E prime ratio. So overall, the Explorer HCM really represents an important landmark, because for the first time, we have a drug that has been developed specifically to target the underlying molecular mechanism of HCM, and by turning this Lamborghini, this Ferrari, into a turbo truck, diesel truck, you are normalizing a number of issues and you're making patients feel better. You are reducing gradients, improving quality of life. Overall, this is really what we were aiming for, and this really opens up a new chapter in treatment of hypertrophic cardiomyopathy. What about non-obstructive cardiomyopathy? It's early to say that we only have a small pilot study, which is promising in terms of reduction in a number of parameters, mostly biomarkers, but we still have to do a 3 study here that the advantage is similarly important. So in conclusion, I apologize for the technical mishap. I hope you were able to follow the last part of the presentation. I think that mavacamten and this sort of molecular approach with allosteric myosin inhibitor is a very promising approach at present for obstructive hypertrophic cardiomyopathy. In the future, possibly expanding to other ends of the HCM spectrum. And what is really important is this will bring attention, will bring investments, will bring the concept that targeting molecular mechanism in cardiomyopathy is possible and ultimately benefits patients in many ways beyond the drug itself, because it does open a new landscape for HCM patients. Thank you very much.
Dr. Balakrishnan. Okay. It's a pleasure for me to introduce the next speaker, Dr. Sandeep Seth. He needs no introduction. He's an extremely well-known cardiologist specializing in heart failure from the All India Institute of Medical Sciences, and he's going to give us a talk on end-stage hypertrophic cardiomyopathy, advanced heart failure, management and transplant indications. Dr. Seth.
Good evening. Hypertrophic cardiomyopathy patients generally have a normal lifespan, but some of these patients develop what is known as end-stage heart failure. And this happens in a very small group of patients, in about 2 to 3% of various series. And the incidence of end-stage hypertrophic cardiomyopathy is about 1 to 2%. Heart failure in hypertrophic cardiomyopathy can occur because of systolic heart failure, which is known as burnt out hypertrophic cardiomyopathy. It can occur because of left ventricular outflow tract obstruction, which is somewhat easy to treat, or it can also occur because of non-obstructive heart failure with preserved ejection fraction, which is usually restrictive physiology that we often have to treat. The mechanism is not very clear. Mechanism is believed to have some component of a genetic basis because it has been found to be having clustering in various families, and patients with similar sarcomeric mutations have been found to end up with end-stage hypertrophic cardiomyopathy. The pathology of many of these patients is similar. Most of these patients have diffuse fibrosis, which is visible on biopsies, on autopsies, and also on MRI now. They also have evidence of macrovascular disease in these end-stage patients. In one of these series of more than 1,000 patients of hypertrophic cardiomyopathy, about 3.5% of these patients develop end-stage hypertrophic cardiomyopathy. Almost 45% of these patients were less than 40 years of age. 66% of these patients died of progressive heart failure or had sudden cardiac death or underwent a heart transplant. These patients were younger, had more symptoms, had a larger LV cavity, and more often had a family history of end-stage hypertrophic cardiomyopathy as compared to the other patients with hypertrophic cardiomyopathy. So familial clustering does seem to be a tendency amongst these patients. If you look at the same series, the diagnosis of many of these patients occurred at the mean age of about 27 years. Onset of symptoms were at about 32 years. Advanced symptoms developed by around the age of 39, 40 years, and they were being listed for heart transplant at the age of about 40 years. So if you look at this in a different way, if you get symptoms around 25 to 27 years, from the onset of diagnosis to the onset of symptoms, the number of years was about 5 to 6 years. From the onset of symptoms till advanced symptoms, another 5 to 6 years. But moment you develop advanced symptoms, within 1 year, the symptoms advance so much that you end up being listed for transplants. So the disease progression from the time you actually diagnose the disease to the time you end up the transplant is only just about a decade. So these patients actually do progress much faster than the other patients with hypertrophic cardiomyopathy. Looking at the pathology, they do have fiber disarray, but they also have extensive fibrosis. They have a lot of small vessel disease. The ventricles are large. There is remodeling. There is cavity dilatation. But you also have some patients in which the cavity is not so dilated and they still retain a markedly hypertrophic ventricle. So both ends of the spectrum are visible. Looking at the genetic basis, this is a series of 26 patients who underwent genetic screening for various mutations, and they found that there were a number of mutations in the myosin, troponin, and some other mutations. Some of the patients were related. So 4 patients were related in this series. 2 were sisters and 1 was an aunt and a nephew. 62% of these patients had a family history of hypertrophic cardiomyopathy. 31% had a family history of sudden cardiac death. So the family history is a strong component. 69% of these patients had paroxysmal or chronic atrial fibrillation. Half of these patients had mutations in the sarcomeric genes. They were either in the myosin heavy chain or myosin binding protein or in the troponins. And only 13% of these patients actually had double mutations, and all were homozygous. So the concept that they could be because of multiple sarcomeric mutations does not seem to hold out in this particular series. 4 out of 7 mutations were actually mutations which have been previously associated with heart failure or heart transplantation. This particular paper does suggest that there could be a concept of malignant mutations which could be associated with a bad prognosis. But there are other papers which suggest that the same mutations may not always have a bad prognosis. The data of that same study depicted in the form of a table again suggests that there's actually not much of difference between the transplanted and other hypertrophic cardiomyopathy patients. patients. So the patients in terms of genetic mutations are relatively similar, though some of the patients who end up with end-stage heart failure you have some preponderance of malignant mutation, though it's not statistically significant. That was the background, but coming to the main topic, how do you manage these patients with hypertrophic cardiomyopathy who have gone into end-stage heart failure? The standard management, of course, is similar to all other patients with heart failure, the ABCD of heart failure management. They all get some form of vasodilator, either ACE, ARB, or non-ARNI. They will get a beta blocker in a reasonable dose. They will get a diuretic, plus all the supportive care that they need in terms of diet management, vaccines, and other care. If they have a LVOT obstruction, of course, they have to be considered for a myectomy or a alcohol ablation. What else can we do? We have to look for atrial fibrillation. Rhythm restoration in these patients will definitely be beneficial. There is a role for pacing, role for transplant, and let me go into these in some more detail. Catheter ablation for atrial fibrillation has been found to be useful in patients with hypertrophic cardiomyopathy. In this series of 61 patients where they did catheter ablation for hypertrophic cardiomyopathy, what they found was that younger patients with smaller atrial sizes with milder symptoms were the patients who had the most benefit with RF ablation. But the patients who had large atrial sizes and were worse in terms of NYHA classes were the patients in whom there was a recurrence of atrial fibrillation. So actually, patients who need it most, the patients or the sicker patients will not benefit, and probably you need to intervene early. The moment the atrial fibrillation occurs is probably the time when you need to intervene early. Pacing also is beneficial. So if you have patients who are suitable for biventricular pacing or left bundle branch block, in those patients, biventricular pacing is definitely going to be helpful. They have been found to cause an improvement in one function class, an improvement in left ventricular function. And the decrease in the QRS width also. But there are patients in whom you cannot do biventricular pacing, medical therapy does not work. There is no atrial fibrillation which can be ablated. So that is where the concept of end-stage hypertrophic cardiomyopathy comes. And for that, how do you diagnose end-stage hypertrophic cardiomyopathy? There is an algorithm called I need help. Patients who are requiring the use of inotropes, who are persistently staying class 3 or 4, or persistently having elevated natriuretic peptides, have an end organ damage in the form of elevated renal function, whose ejection fraction has dropped below 35%, who are requiring repeated defibrillator shocks, who are having recurrent hospitalization, who are having persisting edema or elevated PA pressures despite escalating diuretics, low blood pressure, high heart rates, not able to tolerate even beta blockers or vasodilators. So these are patients whom you diagnose as end-stage hypertrophic cardiomyopathy, where a left ventricular assist device or a heart transplant may be only the final options. So how will the patients with a left ventricular assist device fare as compared to other patients, for instance, patients with dilated cardiomyopathy? There are limited data because very few patients with hypertrophic cardiomyopathy have actually gone for a left ventricular assist device. Even our own experience is limited. We only had one recent patient with a hypertrophic cardiomyopathy who was given a LVAD. So very limited data is available on that. So this is data from Intermax. So they had 104 patients as compared to more than 8,000 patients with dilated cardiomyopathy who underwent a LVAD. So they found that the overall survival and adverse events after LVAD was similar, but they did find that patients in whom the ventricle was small, that means the ventricle less than 5 centimeters and diastolic dimension, had an inferior survival. So overall, the patient with hypertrophic cardiomyopathy will do as well unless the ventricle is very, very small. What about heart transplant? So if the patient has end-stage heart failure, The results of heart transplant are similar, 7-year survival of 94%, which is similar to patients with dilated cardiomyopathy undergoing a heart transplant. Looking at the series of patients who underwent a heart transplant as compared to patients who did not undergo a heart transplant, again, a clustering of family history of hypertrophic cardiomyopathy, family history of sudden cardiac death, family history of end-stage heart failure, and these patients were sicker and NYHA class 3 and 4, larger hearts, and lesser ejection fraction in patients who had to be listed for a heart transplant. The age of diagnosis was lesser, and the evolution from the time of diagnosis to being listed for a transplant was much shorter. So to conclude, the disease entity called end-stage hypertrophic cardiomyopathy is not common. It's about 3% of the entire group of hypertrophic cardiomyopathy. The cause is not very clear. The standard treatment of heart failure works in many of these patients. Some of these patients also benefit from pacing, atrial fibrillation management. But after that, if the patients develop end-stage heart failure, which can be diagnosed using the algorithm I need help, they will also benefit from a left ventricular assist device or a transplant, which is equally beneficial in these patients as it is beneficial in other causes of end-stage heart failure. Thank you very much.
We'll start with a question to Dr. Jacopo. The drop, you said that there is a drop in the ejection fraction. It's a concern. So does it mean that there is a high chance these patients will progress to a end-stage heart failure earlier than patients who are not?
Well, first of all, a is in the end stage bears to do not of energetic NHC microvascular ischemia, and this drug. I'm sorry, I'm told you can't hear me. Can you hear me?
Yeah, there is some disturbance.
No, actually, you're breaking up.
Okay.
Maybe.
Yeah, you can. Yeah, you can try now. Yeah.
Okay, so the drug is actually aimed at preventing end-stage progression because it's aiming at preventing, energy propagation and fibrosis, and this is what it does in the animal, for example, as well as as tissue ischemia. The fact that you can have transient fall in ejection fraction is a totally different mechanism. It's because you are inhibiting myosin deliberately. But of course, this is done in a targeted way. It's done in a sort of a titration, and it is totally reversible from what we can tell. So hopefully it's a totally different mechanism and different consequences. Of course, we want to be cautious, and we have long-term data, safety of the drug. Every single patient in the study had an ejection fraction below a certain threshold was put on washout and recovered completely.
There was a 10% of the patients had a stress cardiomyopathy, very, very unusual happening in the trial. So what is your comment on that?
Can you repeat? I didn't understand. 10% patients?
No, some patients in this group, in the trial group, had stress cardiomyopathy-like features. So, is it so what is your comment on that regarding the progression of LVD?
Stress cardiomyopathy.
Yeah.
So stress cardiomyopathy, yes.
Yeah.
Two patients had that. However, one in particular was in the washout phase, and the other had low pharmacokinetics in blood. So
have to look into that. We are looking into that. Stress cardiomyopathy happens. It happens more often. It does have tract infections. So to some extent, you are expecting to have apical ballooning in a cohort of obstructive cardiomyopathy.
Correct. Yeah.
We just have to check whether down wash out of the drug maybe and the actual prevalence that we have seen is not different effect from reports on apical ballooning.
There was a reduction in the troponins in this group of patients compared to the controls. This is in support of your theory that they will have a better outcome on follow-up.
I think troponin not all patients release troponin. Patients who release troponin probably have some degrees of cardio spring and strain, and troponin release is associated with adverse outcome. So, of course, we don't know whether looking troponin survival, but it is a powerful marker of adverse outcome. So we do think it is an important thing. In any cardiac disease,
this drug works almost similar to what disopyramide does. So are you planning any comparative studies comparing with disopyramide and mavacamten?
Yeah, so the drug not pyramide. I mean, it's a very different drug, very different action, and very different efficacy. So I don't like to say that this is similar to disopyramide. Disopyramide is a negative inotrope because strong action on the peak sodium carrier, so it's a stream effect. It does nothing. We studied this in vitro. Disopyramide does not affect sarcomere contraction or affinity or of the actin for mass. So it's totally different mechanism.
Harikrishnan,
it is a drug study. Sorry.
Go ahead. I'm sorry.
In the Valor study, they will. Okay, go ahead.
Okay, KK, I think you can take over. I think difficult to.
Yeah, I've just been asked by the organizers that I should also have the other audience questions addressed. So I had actually sent the audience questions to Dr. Balaji up front via WhatsApp. And Dr. Balaji, are you with us? Can you unmute yourself, Balaji?
Can you hear me?
Yeah, very well.
Sorry.
So you're familiar with the audience questions, but you can, just for the sake of everyone, I'll just read it out. First question is, at what age should we do cardiac MRI in children once you have a diagnosis of HCM?
Yeah, if it's a phenotypic diagnosis, if the child is already showing some features on echo of hypertrophic cardiomyopathy, then we do a MRI at that first opportunity. At least it establishes some kind of a baseline. Occasionally it shows some surprises, but that's very rare. The important thing is in children, we are able to get very, very good pictures by echo. And unlike in adults, the likelihood of missing hypertrophic cardiomyopathy because the echo is not good enough is relatively much lower in children. So I think it's important to do an MRI at the first visit.
And at what age do you expect them to have a late gadolinium enhancement and those issues that you're worried about? At what time do you anticipate and when do you sort of look for that? How do you follow that?
Yeah, there's no good answer to that question. It really depends and varies from patient to patient. I've seen patients with significant LGE as young as 5 years old, but that's very rare. Mostly it's in the teenagers that we start seeing LGE starting to appear. And then, as I said, this is in children, the problem is everything is very dynamic. And sometimes we have to, depending on the echo findings, we've done MRI sometimes annually in some patients because of the increase in the LGE.
You mentioned about the LVOT obstruction having an inverse correlation in 2 studies. You showed that happen. Dr. Ramakrishnan wants to ask the role of additional right ventricular outflow obstruction in prognosis with HCM. I think mostly it happens in the vasopathies that you have this additional RVOTO.
Yeah. So, it's mostly in the Noonans and the rasopathies that you see the right ventricular outflow tract obstruction. And it's a relatively lower incidence. It has to be managed. Sometimes it needs surgical relief. Rarely can it be relieved with, if it's valvular, sometimes we see significant valvular obstruction in Noonans, for instance, but rarely does it respond to balloon dilation. Oftentimes needs surgery. It's luckily relatively rare. And I can't recollect a single sarcomeric HCM patient with a significant right ventricular outflow tract obstruction. As far as the inverse relationship with the LV outflow tract obstruction and the sudden death, this is a very sort of a controversial finding. I think we were the first to report it, and it was actually very difficult to publish our paper because we found this association, and a lot of reviewers kept asking questions about this relationship. Unfortunately, the data is the data. This is what we found. Why this happens is still a mystery to us as it is to many people. And I have my theory. One of my theories is that hypertrophic cardiomyopathy obviously is a very pleomorphic disease with multiple different phenotypes, presence in different people in different ways. So I think there is a sudden death phenotype that is predominantly an arrhythmogenic phenotype, and then there is an outflow tract phenotype, which is predominantly patients who develop left ventricular outflow tract obstruction. In childhood, these phenotypes look relatively separate from each other. And as people get older and they have left ventricular outflow tract obstruction for a significant amount of time, 1 or 2 decades or more, maybe that increases their risk of sudden death. And so in effect, the 2 phenotypes seem to kind of merge a little bit later on in life. So that's kind of my speculation. I don't have any proof for that. But anyway, at this point, all we can say is that if you're a child and you have significant left ventricular outflow tract obstruction, you shouldn't put in a defibrillator just because they have significant left ventricular outflow tract obstruction. That would be one of my takeaway points.
That's very important.
Sometimes you send them for myectomy, and there is always the sort of the attraction, if you will, when you do the myectomy. Why don't you place some epicardial leads, etc., and come out with a defibrillator? More lately, I've tended to avoid that and just deal with them separately from the myectomy to the ICD question.
Okay, I think the other chair.
Dr. Balakrishnan, could you pose your questions from the audience to Dr. Sandeep, please? Yeah. You're muted, Dr. Balakrishnan. You have to unmute yourself.
Can you hear me now?
Yeah, quite loud and clear.
Okay, there are a couple of questions. The first one is to Dr. Sandeep says, and actually it's been addressed to me as well. What is the representation of HCM patients in your heart transplant cohort? Dr. Seth?
Yeah, I seem to be having 2 streams running. I just get the other stream finish. Yeah, what's the question again?
The first question, in fact, is addressed to both of us. What is the representation of HCM patients in your heart transplant cohort?
I'm sorry, just repeat.
What is the representation of HCM patients in your heart transplant cohort? Okay, there are a couple of questions. The first one is...
Yeah, I think we have had only one. Yeah, we have had only one patient. Yeah, I got the question. Yeah, we had only one patient with end-stage heart failure. What's the question again? Yeah, we had one patient of heart transplant who had an end-stage HCM, and that patient has done very well after that. One patient with the HCM and end-stage heart failure had to go for a LVAD. So that out of our patients of 73 patients, that is our experience.
Okay, and if I can add our experience, we have, I think, done close to now 365 transplants, out of which 110 have been pediatric transplants and the rest have been adults. The incidence of hypertrophic cardiomyopathy is roughly 20% in our pediatric practice and about 15% in the adults. These patients are sicker than the dilated cardiomyopathies. They have more pulmonary hypertension, more renal dysfunction, and they are in general sicker. Their PVRs are often higher. They have often got ascites. But surprisingly, when we analyze the data, the outcomes were not different. The outcomes have been quite good. But the challenge is putting mechanical pumps into them. So we've had two patients who had a Berlin heart as a bridge to transplant. And then we had to cannulate the left and right atrium. They needed a BioVad. And we had one pediatric implant of a heart-fed Medtronic pump, where we had to core out the muscle and create ventricular cavity to be able to put the pump. And that patient has done well. I think there are two streams of audio. It's very disturbing. I can't. But surprisingly, when we analyze some technical issue. You already answered the second question. Have you used mechanical circulatory support in patients with HCM, and what are the outcomes? Dr. Seth, you're there? And that patient is...
No, I think Dr. Seth is experiencing technical difficulties on his end. I think
there are two audio streams, that's why.
No, I think he has his YouTube stream on as well. So I think that's interfering. So anyway, shall we conclude the session and we'll move on to the next session. Thank you, Dr. Balakrishnan.
Thank you. Bye-bye. Have you used mechanical circulatory support in patients with HCM, and what are the outcomes?
We had one patient, that patient didn't do very well. I don't know about Dr. Bala's experience. Yeah, I'm there. Our patient with LVAD after HCM didn't do very well. I don't know about Dr. Bala's experience.
No, I think Dr. Seth is experiencing technical difficulties. Yeah, so we'll start off with the next session, which is an interesting two interesting talks. One is, so the session 6 will be chaired by Dr. Ajay Bal, who's a professor of cardiology at PGI Chandigarh, and joining him will be Dr. Soumitra Ray, who is a professor of cardiology at the Vivekananda Institute of Medical Sciences. Next slide, please. So this is a different talk. So far over the last 2 days, we've talked about the patients, their clinical profile, and the heterogeneity and the various management issues with patients with HCM. Now we're going to listen to Ms. Lisa Salberg, who I would categorize as a force of nature. So she is the founder and CEO of the HCMA, which is the Hypertrophic Cardiomyopathy Association, and it is the largest patient support and patient advocacy group in the world. And I've had the opportunity and the pleasure to have worked with her on numerous occasions. So in terms of patient support and advocacy for patients and their families, we'll listen to a short segment from Lisa from her experience. Over to you, Lisa.
Good morning, afternoon, or evening. I'm not exactly sure what time it is in the time zone you're watching. My name is Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association, and I wanted to take a few minutes to tell you about the organization and some of the services that we offer, as well as a little history. So let me begin. The HCMA was founded in 1996 as a nonprofit organization in the United States, yet we reach patients in approximately 48 countries at this point. And over the past 25 years, we have worked to provide education, support, and awareness to the HCM community, as well as develop many programs, including our Center of Excellence model. When patients are diagnosed with HCM, there is one pathway that we follow. When we are working with general community awareness, we are dealing with other issues, some legislative issues, community awareness on the disease itself, CPR and AED legislation, professional development, dispelling some of the myths that are associated with HCM, like it's only an athlete's problem, or it's only a male problem, those types of myths. We do a little media outreach, and we try to help people understand what the signs and symptoms are so that that can lead them to diagnosis. Once somebody is diagnosed with HCM, they cross over to the other side of our care model or our services, and that is very in-depth HCM education, one-on-one phone calls, helping patients learn how to navigate the medical systems in their country or in their state, helping develop centers of excellence within the United States and soon to be abroad. COVID has put a little bit of a damper on that project right now. We provide emotional support to patients, insurance appeal support, grief support, not only for the death of a loved one, but for dealing with a new diagnosis. And we help people adjust the sails of their lives if their jobs might be implicated by their new diagnosis. And we also work on educating people about the role of clinical trials. Patients with HCM are often met with misdiagnoses prior to their appropriate diagnosis of a hypertrophic cardiomyopathy. The most common misdiagnoses are asthma, representing 19% of the population, mitral valve prolapse, which is about 14%, panic or anxiety attacks, which is 17% of the population, depression, which is 18%. It's important to note on the depression issue that we know that patients with cardiac disease have a higher level of depression, but these individuals were not diagnosed yet. They were just told that their failure to want to get up and out and be active was depression as opposed to related to their cardiac status. 51% of the population had been told that they just had an innocent heart murmur. However, when you take a look at all of these features, we have techniques now and we have the ability of artificial intelligence and machine learning that can actually help us through electronic medical records. If you look at family history of any kind of cardiac disease, atrial fibrillation, early cardiac arrest, etc., on top of asthma, murmur, athletically induced asthma, panic attacks, any of these features, this might be a key to unlocking a lot of hypertrophic cardiomyopathy within your own medical center. So we encourage you to take a look at that. So we've developed a program called HCMA Recognized Center of Excellence. Now this program is multifaceted and started out with just some personal relationships over the years, and then was realized that we needed more programs because we have 325 million people in the United States alone that have hypertrophic cardiomyopathy, not to mention the rest of the world. So we started to develop these programs, and as of right now, we have 41 programs. They're not all equal in size and scope and services, but they are a place for patients with HCM to receive high quality, comprehensive care. Some of them have referrals to other programs for things like surgery and transplant and maternal fetal medicine, and some of them are all-inclusive programs in one establishment. As of today, the HCMA has over 45,000, actually it's closer to 50,000 now, patients assigned to one or more of the centers of excellence that we work with, and we know that they have a very high quality of care in these programs. We'll talk about that in a second. We will be building out some more programs as the 2021 approaches. We didn't do any real site visits in 2020 because of COVID, but we're doing our first virtual in a couple of days, and hopefully that'll work out well. We have a number of programs that we're looking to build out to, and hopefully, again, internationally will follow. So we have to have a little fun in HCM. It's a very serious topic. So we created this slide to help people understand what an HCMA Recognized Center of Excellence is. So we have our HOCMologist, or our director of an HCM program, and he has all these patients, or she has all these patients, and they need to go through imaging, an EP evaluation, a heart failure evaluation, genetics, and potentially mental health evaluations. And as these patients go through the funnels, of all of these different subspecialties, they may land in a bucket outside of the HCM program directly. And it's really important that these patients, once they're seen in EP or maternal fetal health or genetics or mental health or interventional cardiology or surgery, that they find themselves come back to the HCM center director or the program so that we don't miss anything. Early on in the HCMA's career as developing these programs, some patients would go to EP because they had atrial fibrillation or they were viewed to be at high risk for sudden death. And they went to EP and they kind of stayed there. Unfortunately, the heart muscle can deteriorate over time, and that doesn't always get caught by electrophysiology. So it's really critical that the cardiologist and at the head of the HCM center, the director or a member of that team, are involved in this patient's care all the way through the process. So you're going to hear more about this in coming weeks when the American Heart Association and American College of Cardiology release their new guidelines for the treatment of HCM. But generally speaking, there's different types of programs. There's very comprehensive programs that we work with that do have the HCMA Recognized Center of Excellence distinction. And then there's smaller programs that have the distinction as well, because not every program is going to have the same level of expertise in all areas. So by representation of stars, 5 stars, 3 stars, 2 stars, etc., you can see where you're going to get the most comprehensive HCM care. And in a comprehensive HCMA Recognized Center of Excellence, you can pretty much do everything there. But in a primary center, you may not be going there for surgery. You may not be going there for transplant. You may not be going there for pregnancy care. You may need other, need a referral into a higher volume center for that. Primary cardiology does hold a role, and it's critically important that all of our patients have primary cardiologists in the community to assist them. So that's how we look at our care model. What do we know about this model from the patient's perspective as well as from the clinician's perspective? Patients surveyed found that their care at a center of excellence was both found improvements in their quality of life physically as well as emotionally. They finally felt understood. Outcomes from invasive procedures have lower complication rates. The ability to participate in clinical trials is at these larger centers. There are better outcomes with surgery. We know that from a number of different studies that have been done. We know that patients have a likelihood to be treated with the appropriate level of care, not too much, not unnecessary procedures, and not being ignored or not having risk stratification performed on a regular basis. And we know that these patients are much more likely to receive care that is appropriate and less likely to get inappropriate or contraindicated care. So we know centers of excellence work. We know that patients are happy with them and physicians are happy with them, as are medical centers. I want to talk a little bit about some of the services of the HCMA. We have a very large social media presence. These are some of the headers from our Facebook communities. While we have a Facebook community general page, currently followed by about 12,000 individuals, we also have community support and discussion groups for patients specifically. Patients must go through an approval process to be brought in. And in the coming years, we are going to be building out this Facebook communication module to include other programs around the world that we're looking to build up now. So we have some programs that we're partnering with in a number of different countries. And we're going to be calling these programs HCMAI, which is HCMA International. And each one of these outreach efforts with patients like myself who are going to be in other countries speaking the native language, we will have our posters put into the language of the community with help from our partners in that country. We will build up networks of physicians within those countries. We're currently underway to build up Sweden and a few other places, but we'll hold that for another day. Hopefully we'll get to India and Northern Africa in the coming years as well. So stay tuned for that one. And if you are interested or if you have patients who might be interested in participating in this program, please do let me know. You can reach me through the HCMA website. We're building out online support group meetings, which will start meeting in December of 2020. And there will be several different support group options every week with different hosts and different topics. Some of them will be standing appointments, such as pre-myectomy or transplant. Those will be standing meetings that'll have a standard agenda every meeting so that everybody can kind of get online with that. And others will have different meeting agendas, and they will ebb and flow with the needs of the community that are participating in that particular group. And members of the organization, as well as those who are non-members, are welcome to join us for these meetings. Next year, we'll be building out our peer-to-peer Big-Hearted Friends network. Think of us as what we call in the United States eHarmony. It's a dating site. Think of it as the eHarmony of HCM peer-to-peer relations. We're going to be doing survey-based initiatives to match patients with their appropriate peers so that they can get the support that they need. So stay tuned to us for 2021 for that one. We are working on a program called Share Your Story, which will include podcasting through our Tales from the Heart podcast, which you can hear on Spotify or wherever you get your podcasts. These Share Your Stories will be patients, physicians, industry representatives sharing their aspect of how they're involved in HCM or how HCM has impacted their life. I do also encourage you to join us every other week for Tales from the Heart, where I speak with either Dr. Martin Marin or Dr. Harry Lever, and we discuss topics of interest to the HCM community, specifically for the patients, but we have a lot of medical professionals joining us for that one too. I want to tell you a little bit about our legislative subcommittee. While you guys are not in the United States, we are building up initiatives to change some legislative language in the United States to include well child examinations, to include cardiac components, as well as improving for pre-participation screening physical initiatives, as well as supporting good CPR and AED legislation, and supporting federal laws that ensure patients have access to insurance coverage regardless of pre-existing medical conditions. All right, let's go to the next slide. If you have not seen this yet, I do encourage you to stop by YouTube and visit this page and take a little bit of time. It's a 4.5-hour program. The Hypertrophic Cardiomyopathy Association held an externally led FDA patient-focused drug development meeting, which allowed patients to explain in their own words what the burden of disease is for those with HCM. A report will be issued shortly called The Voice of the Patient, and we were hoping that it is a guide for those who are going to be involved in clinical trials to create good endpoints that have meaning to the HCM community. And I hope that that taught you a little bit about the Hypertrophic Cardiomyopathy Association. I appreciate this time and being able to join you. And my thanks to the program sponsors and the leadership for bringing you this program and allowing me to have a few moments to speak with you. I'd like to thank all of our HCMA Recognized Center of Excellence partners, the staff of the HCMA, our board of directors, our volunteers, and of course, Brandy, who is my heart donor. I lived with HCM for 36 years until 2017 when I received a life-saving heart transplant. And I'm here to tell the tale today that you can survive HCM and you can also live with it. So thank you so much for your time and attention. If there's anything else you need from us, please reach us at 4hcm.org. You can email us at support@4hcm.org as well. Thank you and have a wonderful day.
Thank you, Lisa, for that wonderful talk. I think your personal story and what you offer HCM patients is quite remarkable. And the last talk, the concluding talk of our 2-day session is none other than by Professor Perry Elliott, Professor of Cardiovascular Medicine at the University College London, and the research lead of the Inherited Disease Cardiovascular Disease Unit at the Barts Hub. Over to you.
Hello, my name is Perry Elliott. I'm a professor of cardiovascular medicine at University College in London and St Bartholomew's Hospital. And it's a great pleasure to be here, albeit virtually, with you to discuss the road ahead for hypertrophic cardiomyopathy at the end of this fascinating 2-day symposium. These are my conflicts of interest. So before I talk a little bit about the future of this disease, I think it is quite useful just to very briefly review with you where it is that we come from, because I think it's this that sets the agenda for our future clinical priorities and clinical research. The story of this disease, of course, goes back many centuries, with various pathologists, clinicians, and scientists who described hypertrophic cardiomyopathy in all its various guises. The modern story of hypertrophic cardiomyopathy is often said to have started with Donald Tier's description of individuals who had died suddenly and who had this classical histopathological phenotype that we now know so well, of asymmetric septal hypertrophy, myofiber and myocyte disarray, extensive myocyte fibrosis, small vessel disease, and mitral valve disease. This timeline, published by Barry Maron in 2009, shows some of the key steps in the development of our understanding and management of this condition up until the late 2000s. And you can see that it's dominated by technological innovation, which have allowed us to interrogate the clinical phenotype more easily and in more detail. And it's also characterized by this focus on outflow tract obstruction, which of course has been a major preoccupation in our management of this disease. Indeed, until very recently, therapeutic innovation in hypertrophic cardiomyopathy was focused very much on the treatment of outflow tract obstruction, whether that be surgical intervention, drug therapy, beta blockers, diazepam, verapamil, septal alcohol ablation, or indeed dual chamber pacing, which until relatively recently was one of the few interventions that have ever been subjected to a randomized trial in this disease. Of course, for patients and cardiologists alike, one of the major preoccupations with hypertrophic cardiomyopathy is the prevention of this, sudden cardiac death, something that we know is relatively rare, but which is preventable and therefore a major priority for management in the clinic. Once again, there have been various schools of thought about the best approach to risk stratification, but in essence, there's now coalescence around the principle that we can identify a number of different clinical features which allow us to identify patients who are at high risk and who therefore may benefit from ICD therapy. One of the major innovations in the management of this disease over the past 20 to 30 years. Of course, many patients with hypertrophic cardiomyopathy are relatively young and therefore are likely to have their device for many decades, which in the long term can lead to complications with leads and so on. But here again, we're seeing technical innovation with the development of devices such as the SICD, which avoids the need for intravascular leads, and therefore in the long term will hopefully reduce the complications associated with ICD therapy, and which I think is already tipping the balance even further towards primary prevention in the clinic. Now, in terms of questions for the future, one of the perhaps curious ones I want to start with is the epidemiology of this condition. If you go back to the 1950s, 1960s, physicians such as Wallace Brigden at that time were saying that the incidence of cardiomyopathies in general was unknown, but probably much higher than was generally supposed. And indeed, you could probably use exactly the same statement in a review article even now. One of the problems has been that the determination of prevalence has often been based on very selected cohorts, and we've had relatively little data from large populations. But these are data that we've recently obtained from the electronic health record in the UK, showing that the estimated prevalence for hypertrophic cardiomyopathy in particular overall is about 3.5 per 10,000 individuals. Now, this is quite different from the figure that we often use, which is 1 in 500. But of course, these are individuals who are actually within the healthcare system, not asymptomatic individuals out in the general population. From this analysis, however, we do learn a number of things. We see actually that rather than being a disease which is overwhelmingly predominant in the young, actually the mean age for most populations is now in the middle decades of life. And the other thing that we're seeing is increasing reporting of this disease. So for all cardiomyopathies, we've seen an increase in the prevalence of about 60%, which almost certainly reflects to some degree greater awareness and acceptance of the diagnosis by cardiologists when they see people with unexplained left ventricular hypertrophy. The reason I've raised this as an issue for the future, however, is that it's only by identifying patients, understanding where they are and how they're being treated, that we will be able to genuinely impact on morbidity and mortality in this disease. This is an example of what I'm trying to say here, which if you look at, again, the electronic health record in the United Kingdom, if you look at individuals who have a hypertrophic cardiomyopathy phenotype, then the prevalence of atrial fibrillation in this instance is about 16%. But only 1/4 of these individuals with a history of AF were actually receiving anticoagulants, showing despite the fact that we have clear society guidelines for the management of AF in this instance, but other aspects of the disease, in the so-called real world, undertreatment is probably still common. A second focus, I think, for the next decade or so will be a return to an interest in the genetics of this disease. Hypertrophic cardiomyopathy was the first monogenic cardiac disorder for which the underlying genetic architecture was identified in the late 1980s by the Seidmans in Boston and by clinicians such as Bill McKenna, studying large families in which a mutation was identified in the gene encoding cardiac myosin heavy chain. It soon became apparent, however, that this did not account for the majority of disease, and there was then a rapid period of discovery where mutations in pretty much all of the elements of the cardiac sarcomere were identified, although the two commonest remained beta myosin heavy chain and cardiac myosin binding protein C. Now, this discovery has continued to the present day with more genes accounting for smaller proportions of disease, maybe 1 to 2% of disease, and for the increasing recognition that within populations of patients with hypertrophic cardiomyopathy, there are individuals who have what were previously thought to be very rare disorders, both genetic and acquired, such as Fabry's disease, Noonan syndrome, and amyloidosis. However, despite the early discovery of the genetic architecture of this disease and a considerable amount of research on the subject, genetic testing still remains poorly applied in the clinic. Now, this used to be because genetic testing was expensive, slow, and difficult to access, but this now in most advanced healthcare economies is no longer an issue. So we now have rapid access to genetic testing in most circumstances. The problem, I think, is in the general concept of its value as a tool. Now, of course, its major tool role, I think, has been in the context of family screening, where if you have an individual with disease, you can go to relatives, genetically test them if the proband has an identifiable mutation, and rule them in or rule them out of further evaluation. And this is important because we know from longitudinal studies of asymptomatic or pre-symptomatic mutation carriers that at least half will go on to develop disease. And as soon as they develop that disease, they then, of course, become prone to all of the complications that the index case in the family was also prone to. So genetic testing in this context allows us not only to stratify families for screening, but also to identify individuals who may be at future risk of developing complications. But I think where the real excitement now about genetic testing is in the focus on new therapeutics. We're going back to our understanding of the basic pathophysiology of these mutations. In the late 80s, early 90s, we understood a lot about how these mutations influence the function of sarcomeric proteins. So, for example, in beta myosin heavy chain, we know now that there are mutations that affect this interaction between the myosin head and the actin filament. And some of these mutations actually cause what is often in a shorthand called a hypercontractile phenotype, where you have increased binding between the heads and actin. And it's this increased binding which is thought to result in inefficient energy utilization and the activation of downstream pathways that result in myocardial hypertrophy. Based on this understanding, there is now the hypothesis that if you can reduce this hypercontractile cellular phenotype, you may reduce the driver to hypertrophy. And there are now a number of small molecules that are in development which do this. And one of these, mavacamten, has recently been trialed in the context of left ventricular outflow tract obstruction. Because of its effect on myosin-actin interaction, it reduces contractility, and therefore one might anticipate that, just as in the case of beta blockers and disopyramide, that this might alleviate symptoms in patients with obstructive HOCM, and indeed that is what we saw in this recent trial, the Explorer-HCM trial, where we saw reductions in gradient, both at rest and with Valsalva and exercise. But equally important, perhaps even more importantly, we saw reductions in BNP, showing a reduction in cellular stress, and also, interestingly, a reduction in troponin T in the plasma, suggesting that the maladaptive cellular phenotype was being favorably affected by this drug. So we will see the efficacy of other agents targeting outflow tract obstruction, I think, in the near future. But in terms of therapeutics, I think it's this question which is going to increasingly dominate the landscape of hypertrophic cardiomyopathy, namely that of the prevention and treatment of heart failure. We know that many patients, probably the majority of patients with hypertrophic cardiomyopathy, have heart failure symptoms, whether that be breathlessness, fatigue, or other aspects of the heart failure syndrome. We also know that the frequency of heart failure increases as patients age. So as we see here from the SHARE consortium, you can see here that the majority of patients actually will develop heart failure symptoms, or indeed have a heart failure endpoint such as death or cardiac transplantation during their follow-up, particularly if they have early onset disease. Here shown in a different way, exactly the same message. This time from the HOCM Outcome Investigators Consortium, where you can see in the dark bars the prevalence in different decades of sudden cardiac death. This curve has been replicated for decades now, with a peak in sort of the 20s and 30s, which declines as the patients age. But here in light grey, you can see that heart failure, the proportion of people dying with heart failure, is pretty constant throughout the life course of this disease. And this really shouldn't come as a surprise, because this is, after all, a myocardial disease. And we know that with time we see progressive fibrosis with reduction in contractile performance, myocardial thinning, ventricular enlargement. Now, at the moment, we have no active therapies which we believe alleviate this progression. There are a number of drugs that have been used over the years to treat hypertrophic cardiomyopathy. Some of them are simply repurposed drugs which are used in other contexts, ACE inhibitors, ARBs, and so on. But once again, I think there is reason to be very hopeful that some of the drugs that I've already mentioned, such as myosin-actin modulators, this time drugs that increase the affinity for myosin and actin filaments, or indeed other small molecule therapies which affect other downstream pathways in patients with hypertrophic cardiomyopathy, have promise in maybe slowing, preventing, or perhaps even reversing some elements of the heart failure phenotype in this disease. I think what we're ultimately hoping and dreaming of now, though, is a cure for the condition. And in the genetic forms of the disease, this may be possible through gene therapy, something that we've been talking about for many decades, but which is now no longer science fiction. Gene therapy is being used in a number of different contexts now, whether that be skeletal myopathies or haemophilia or many metabolic disorders. And whilst there's a long way to go in trying to develop platforms for gene delivery, whether that be AAV-delivered vectors or other genetic strategies such as antisense oligonucleotides, silencing RNA technologies, there is now enormous interest and activity in this area, which for the first time gives us the possibility of actually targeting the underlying driver for the disease. as we approach that dream, I think our concept of how and when we intervene in this condition will also change quite dramatically. At the moment, we tend to focus on the individuals who are presenting with symptoms or have a clear phenotype which predisposes them to sudden cardiac death. But as we start to develop therapies that modify the underlying pathophysiology of the disease, we can start pushing the intervention period earlier in the natural history to asymptomatic patients, or perhaps even to patients who carry a mutation but have not yet developed a phenotype. Now, is this science fiction? Well, at the moment, possibly, but we are already seeing in animal models, here in the context, again, of mavacamten in a mouse model of hypertrophic cardiomyopathy, that early administration of the drug can, in fact, prevent the disease phenotype from developing. Now, we've been here before, so we have to be very cautious with this kind of study and translating it into man. But with the number of therapeutic strategies now being explored, I think this is now something that we can dare to imagine, actually preventing disease development in mutation carriers. So to finish, I think that the journey of hypertrophic cardiomyopathy is by no means over. We already have very effective interventions in the form of treatments for outflow tract obstruction, a defibrillator. We now have randomized clinical controlled trials of drugs which can clearly help to treat symptoms, and in the next few years we'll learn whether these drugs can also modify the natural history. As always in hypertrophic cardiomyopathy, if we dream, we can actually solve problems, and I think this is something that we're going to see very soon within a 10 to 15 year horizon. Thank you very much for your attention.
Thank you, Professor Elliott, for a very excellent and very crispy delivery of the past, present, and future of HCM, which actually effectively sums up what we have learned over the last 2 days and we have discussed over the last 2 days. Now, I have got some interesting questions from our audience over here, equally distributed to Ms. Lisa Salbach and Professor Perry Elliott. First, I have the permission to ask Lisa, if you don't mind. One question is that how much of an impact do you think an organization like HCMA will bring to India? Can you guess?
Well, it's not something that I haven't thought about before, and we've kind of talked about this a little bit over the years. I think we can provide a wonderful resource if we could find the proper patient advocates on the ground, speaking the language, understanding the cultural significances of decision-making within Indian families. But I think I would be really excited for any of your viewers to send patients who are bilingual my way, and the HCMA will be more than happy to provide them with some resources to get them involved in our Hypertrophic Cardiomyopathy Association international efforts to just develop more patient models like ours so that we can serve more people. And I think we could get a lot of Indian families the help that they need.
Yes, maybe to start with a website or with the virtual assistance and advice and counseling you can give instead of having actual or field activity in India, which is very difficult for your organization at the moment. Maybe online you can start support.
So first off, let me tell you that we are redeveloping our website, and you will see an entirely new look and feel come first quarter of next year. Additionally, once we do make contact with an individual in a particular country, we update the language of the actual website posters and materials. Then we can create a Facebook community for them. And most people have access to Facebook. So we can create an anchored Facebook page for India. We're really excited to find the right people to partner with to do that. And hopefully we can accomplish that through 2021.
And it will be our job actually to enlighten people about the existence of such help from your side. Excellent. Another interesting question for you, Lisa, is that what is your experience regarding the psychological take-up of ICD by the patient? Do they get depressed? Do they feel panicky, anxiety?
So you're talking about ICD discharges in hypertrophic cardiomyopathy patients. Is there an emotional? Yeah. Okay. So there's definitely a psychological component to all of hypertrophic cardiomyopathy, the diagnosis process, the surgical planning process, the recovery process, and the ICD pathway. It's not just the ICD pathway. Once somebody has experienced a shock, we see pretty much two camps: an incredibly grateful camp that is just thankful to be alive, and the other camp, which is for a period of time, a little post-traumatic stress disorder kicks in. They're very anxious about it's going to happen again. But we have found through patient support and them giving the opportunity to talk to other patients who've experienced the same thing, that it helps to eliminate some of the stress and anxiety and provides them with a little bit of calm, especially in those people who have either 8, 10, 12 years between shocks or only ever have had one. Those who experience storms are very apprehensive and have a lot of anxiety. And unfortunately, they tend to be people who have multiple issues like this. So the psychological burden sometimes can actually cause disability and family strife, and it can require very significant psychological assistance and medication.
Sure. Now it is very relevant. Now only last week AHA has published their updated guideline on the HCM. So it is so very relevant. So I'm really grateful to Professor Narasimhan, because it is so very relevant in the world now. People are thinking about it, and in India really the awareness is pretty low. What may I ask you one thing, because they have emphasized on the exercise, the sports activity, some revamping of those ideas. May I ask you one thing, in your country, because it varies from country to country, what is the status of light vehicle license, driving license for HCM patient? I have got 5 questions. Number 1 is this: the light vehicle driving license. Do they get it? Is there any restriction?
So I'm assuming you're speaking of a regular driver's license for an individual.
Regular driver's license.
So a regular driver's license is fine. Anybody can have one with HCM, even with an ICD. If they've experienced a shock, and the etiology is unknown, or it seems that they are arrhythmically unstable for a period of time, they may be told not to drive for 30 or 60 days. Certain states require physicians report that to the Department of Motor Vehicle. Most don't do it. It's not something that you see happen. Patients know to kind of be careful for that. But generally, general licenses are fine. Commercial driver's licenses, there's been a change over the past few years in the United States. Originally, starting back in probably the mid-'80s, they banned anybody who had left ventricular disease, period, which was kind of silly because there was way more undiagnosed truck drivers with coronary artery disease than left ventricular dysfunction of any sort. So they've recently updated those guidelines within the past couple of years to say, specifically for hypertrophic cardiomyopathy, and we did a lot of letter writing and campaigning for this, that those with stable hypertrophic cardiomyopathy can have a commercial driver's license with the approval of their physician, and only those with ICDs are banned from having commercial driver's licenses in the United States, because there is a very real public health concern about an ICD shock while you're driving a tanker full of flammable materials.
Maybe you can guide the government regarding the higher chances of sudden cardiac death. Those categories of people maybe may not use it. Second is, what is the implication of health insurance in such patient in USA? Do they get easily health insurance with normal premium, or do they have very high premium, or what?
So in case people are not fully aware of this, the United States doesn't have a healthcare system.
Okay.
We have a patchwork that is a disaster, that is just mind-boggling in some of its complexities. So I envy those who have more organized systems, but we have a profit model. So it's a problem. So number 1, the majority of people in the United States get their health insurance through 2 sources. Their employer provides health insurance that is related to their job and is anchored with their employer, and their employer makes the decisions on which plans that they can get into. When you're in that kind of a plan, pre-existing conditions can't count against you under federal law for many, many years, going before the Affordable Care Act. Then the other group of individuals are on Medicare, which is socialized medicine, which most of our country thinks we're not doing, but we are. So they get federal Medicare. They need supplements for that and other policies to go along with it. The other individuals have to buy their own policies. So this is about 25% of our population, and they either get it through programs through this that are subsidized by the state or federal government, Medicaid, and they can get them if they're low income and no pre-existing conditions count against them there. It was through the ACA for that other 23% that were getting buy your own health insurance. Up until ACA, pre-existing conditions could be counted against them for a period of a year. So if they had HCM, they would have to be good for a year. And then in the second year of the policy, they could actually use it. So it didn't really work so well. So ACA got rid of that. But now the current and outgoing administration allowed what they call mini-med programs back, which were limited coverage, pre-existing conditions counted, and they're basically snake oil. They don't really work. So that's the pathway to get healthcare in the United States, and it is really expensive. Medicare is the affordable one, but you're talking a family coverage plan in the United States is anywhere between $1,200 and $2,000 a month in premiums.
So, good evening, Perry. So, a question for you. What is the current status? Are there any clinical studies on mutation carriers who are phenotype negative?
Yeah, so and good evening as well. I know it's really late, unusually late conference. Yeah, so we've recently published a paper in JACC, but I showed one slide in my presentation. Lorenzini is the first author, where we specifically looked at the natural history of mutation positive but phenotype negative carriers. What we saw was that about half of them went on to develop a phenotype, and there wasn't very much difference between different genes. There was perhaps slightly higher penetrance in patients with myosin 7 mutations. And as I showed, the important thing was that whilst you have no phenotype, then nothing bad happens to you. But as soon as you start to develop the phenotype, then of course you may become prone to disease-related complications. In terms of predictors of the development of the phenotype, men were more likely than women to develop it. If your ECG was abnormal at your first evaluation, again, that was a significant marker of risk for developing overt hypertrophy. But we did see an alarmingly large number of individuals who actually had a normal ECG, but who had hypertrophy when they were scanned using MRI imaging, usually because of hypertrophy in particular segments that are difficult to visualize on echo, so the lateral wall of the left ventricle or the posterior septum. So that's I would argue perhaps the most detailed evidence we have to date.
And there's a question from the audience that why are specific, let us say the septum, or why are there specific, or the apex, why are there specific walls which are involved in the hypertrophy?
Yeah, it's interesting, isn't it? Yeah, I mean, Lisa used the term hochomologous. This is the sort of thing that hochomologists talk about in bars, well, when we used to meet in bars. You know, why do you get this asymmetry? Why this regionality of disease? I've always thought there are two possible explanations for this. One is the variability in wall strain. So it may be that you get different drivers to the development of the phenotype related to regional differences in myocardial strain. The other thing which I think it may relate to is that the expression of different myocardial proteins varies across the myocardium. This is something we have an interest in, and we've looked at this in animal hearts, and you see dramatic differences in the amount of particular proteins within the septum, the free wall, the right ventricle, the atria. So it may be that we're also seeing that as well. But the variability in the phenotype is striking sometimes even within families. As we've all known, you can get concentric patterns, apical patterns, asymmetric patterns. It's still one of those enigmatic mysteries of the disease.
And would you like to highlight some of the changes which have come about in these 2020 recent AHA guidelines?
Yeah, I think one has already been mentioned, which I think is a really important one, about the more pragmatic advice regarding sporting activities. For that, for me, is actually the biggest win in the guideline, where it actually allows people to live a more normal life, following appropriate expert assessment and intervention where it's necessary. I think we've edged a little closer towards to a global consensus on the assessment of sudden death risk. I think we're seeing a merging of this artificial division between across the Atlantic. Probably for the people in India, watch with bemusement. But I think it's actually there's no real difference now. And I actually think the thing which I think has emerged from this is whether you use a score or whether you tot up your individual risk factors. I think it's this promotion of a dialogue with the patient. So it's the assessment of risk is more than just a number. It's about a perception of risk by the patient, by the physician, by the healthcare system, and who pays for the device. But it's a much more sort of dynamic, flexible model, I think, for risk.
Can I comment on that? So yay, we're more in alignment. I agree with you, and it's a good day in HCM. However, not however, but an and. I love, as you know, the shared decision-making concept in all aspects of HCM. But I think there's an unintended consequence with this new guideline. And I think that is the burden that this shared decision-making puts on the patient and the family, and especially the patient caregiver, which means the individual has HCM themselves, they're balancing their own needs and their own disease pathway and having to make decisions either for or with a loved one about their pathway. This brings an enormous amount of stress to the family. And when a doctor tells a patient, do X, that's clear. When they say you could do X, all right, well, how do I make that decision? And giving patients the resources to help them make well-informed decisions goes beyond the doctor's office walls and the appointment. And thank you, but thank you not for the guidelines, because you just made me a lot busier. And I'm hoping that patients will reach out for information so they do make well-informed decisions that don't have a bias from an individual physician for them, but they get to really explore and make the right call for them. And that is going to be a really interesting thing to play out and see how it goes. But we all need to work together, the patient community, the industry, the payers, and the scientists, and the physicians and the clinicians. We all need to get involved here. And I'm looking forward to a new day in HCM that is actually now guideline based.
Yeah. I think what I would respond, I think it's always been that way, Lisa. I don't think this guideline changes that very much. But I think the problem still is that physicians, doctors generally don't really understand the concept fully of shared decision making. And shared decision making is actually a science. It's a whole area which relates to communication, the conveyance of risk. If there's a difference between saying someone's got a 2% risk or 2 in 100 risk, I actually think we need to work really hard on supporting patients, but also on cardiology training, so that we ourselves understand what risk is and understand the dynamic that you're describing to help patients come to a decision which makes sense for them.
I think we have lessons to learn from other chronic diseases.
Yep.
And I think one of those lessons, when you go to a cancer center, I do not wish cancer upon anybody, but it really talks about holistic care, how the mind-body connection is important, how stress and stress management is important, and how mental health support is important. In cardiology, we're not training people to think in this light, when in actuality, we have a greater burden than many patients with cancer. Cancer, there's a beginning, middle, and an end, and it's in a finite cycle. We are lifelong patients, lifelong families.
Lisa and Perry, I think we need to have a separate meeting on this issue. No, truly, I'm glad we meet at least virtually on this. I think the fundamental problem is complete erosion of trust in medicine. and physician ownership as clinical leaders. For example, I own up and then I have the courage to say what I think is right for the patient. It's not possible in the modern days system where so much of litigation and so much is driven by guidelines. Medicine cannot be a cookbook medicine. No. And you look at every single senior research, they brush aside all the clinical case reports as though it means nothing. But if you look at the, say, classic example, hypertrophic cardiomyopathy, the description came from 4 cases. And it paved the way. Cobalt cardiomyopathy came from a single case. Sildenafil in pulmonary hypertension was a single case report. Some of that art of medicine, we are trying to kind of shy away from that responsibility of taking clinical ownership on this and mean well for the patient. You rightly said, Lisa.
Lost you.
That what matters or drugs and so on and so forth. What is happening? No, very, very right. Because what is happening is the incentive that is based purely on procedures, I think, is where the problem starts. Unfortunately, we fall into this trap that a cardiologist is defined by the number of angioplasties or procedures or ICDs, and I'm growing out of those things. I think I contribute a lot more in my outpatient when I make a patient lose weight, detect sleep apnea, make a proper clinical diagnosis. Now, modern day guidelines kind of take it for granted that clinical diagnosis is a given, and your metrics for improvement is either HbA1c or prescription of beta blockers. But there's so much more to medicine than just cookbook medicine. I think you should all come together for a separate meeting, because this is a more important problem which is staring at us altogether, especially NHS. NHS used to be a role model for a lot of us. Most of us in India kind of were trained by the British physicians, and we strongly believe that that's the way to go. And unfortunately, Britain is losing its sight, and you are coming up with more and more guidelines and technology driven. I was just writing to Perry saying that the simple risk score that they have come up with, from whether it's Africa, or Sri Lanka, or Bangladesh, that's one thing which you can apply without MRI, without doing anything. It's a great tool at the bedside. So anyway, please go ahead, Perry.
So I hear you in every respect. Okay, so you should come and listen to some of my lectures at the European Society of Cardiology, which are basically a synthesis of everything you've just said. So I completely agree about the limitations of guidelines. Now, I chaired the previous HOCAN guidelines. I'm heavily involved in other guidelines, not just AHA, but heavily within the European Society of Cardiology. But I think you're right in that we have moved in cardiovascular medicine towards the cookbook approach that you describe. And life and medicine is much more complicated than that. But this goes to the heart of what we do. I mean, I'm flippant. I flippantly say sometimes, but I really mean it, that sometimes in cardiology, we've got 4 diagnoses. Coronary disease, hypertension, heart failure, and a box of funny arrhythmias. And we try to reduce our approach to medicine to those 4 headings. You think hypertrophic cardiomyopathy is a problem? Just think about heart failure. If you want to give me a stroke, mention HFpEF. What a nonsense term that is. Hypertrophic cardiomyopathy is HFpEF. Amyloid is HFpEF. Hypertension is HFpEF. Obesity. The critical thing is to ask the question why. Why does this patient have the symptoms? What are the clinical clues? How do I define the pathophysiology? And how do I modify that with the tools available to me? And that's the old style British education that I had, but it is something that
don't give it up.
but it is something that we're going to have to work really hard to reintroduce.
Right.
Your first point, I disagree with you a little bit though about the loss of trust. Actually, I think the doctor-patient relationship has just become a little bit more complex. It is a much more equal relationship than it used to be, which I think is a good thing. And I think actually, if the more transparent you are, the more that you share the the known and the unknowns of the patient, and you treat them as an equal in the dialogue, actually this mythology of being sued all the time doesn't happen. The problem comes when you hide, or you're not fully transparent in your explanation, or you tell fibs about things, that something is black or when in fact it's white, or vice versa. That's when the trust breaks down. Now, it means that sometimes you've got to work a little bit harder to understand the patient. You've got to work harder to establish the trust. But I still think that as physicians within society, we still have a very privileged position and relationship. So
I would agree that the trust issue is at different levels. People want to trust their primary care physician in a community in the United States because they're the best one in town. But as a primary care physician, and they don't know a lot about hypertrophic cardiomyopathy. And the trust breaks down when that lower level of physician in the HCM care model says, you don't get shortness of breath from hypertrophic cardiomyopathy, or you don't get dizzy from hypertrophic cardiomyopathy. And yes, you do. So there's where some trust gets eroded. But when they get to a knowledgeable cardiologist in the disease state, the bond there is cement. It is tight, it is trust, it is mutual respect when they get there. Getting there is the challenge. No matter what country you're in, it's a challenge to get up the hierarchy in a subspecialty care model. So there I will, agree to disagree on some levels on that issue.
I'm sure we need to have an hour-long discussion, Perry, you, me, and there are 900 people on the YouTube, 900 people who have registered now, and they're all in India. It's close to 10 p.m. So I think, like everything else, we need to wind up. And I have the pleasant task of saying this concluding remarks. First of all, a big thank you to all of you who were able to join us in this troubled times of COVID. And COVID has exposed a lot of inequalities in every single country, and ours is no exception. And this idea on hypertrophic cardiomyopathy, I owe it to Balaji from Portland, Oregon, who kind of came up with this idea. And then most of the heavy weightlifting was done by my colleague Mutaya and Hisham, who put together a lot of good work over the last 2 or 3 weeks, sending mails to you and coordinating. A lot of coordination was done by them. And I would like to thank each and every one of you as a faculty, because it's an immense contribution with a limited time we were able to achieve. And thank you, each and every one of you, because you have taken time from your family and your work. I sincerely appreciate this. Please understand that this is going to be spread, and there's a YouTube link, and this is not only for patients and for several physicians. And truly, we are reaching out globally, and we are able to spread the message across. Thank you once again for this. And for all the moderators who are able to kind of conduct the proceedings on time, I would like to say a big thank you. And the audiovisual team, there was a bit of glitch, but they are just learning, and I take responsibility for whatever has gone wrong. I hope we'll be able to correct it in the next meeting. And thank you for Robin and others from audiovisual at AAG. And last but not the least, for all the delegates who were able to stay till 10 p.m. here and listen to this, still I can see about 800 people there. And it's a big thank you to all the delegates. I think there's a suggestion from Balaji that this should be made as an annual meeting. I fully agree, because I think we are just thinking about it. We'll take inputs from all of you. This can be done at 3 levels. One is to foster some kind of research collaborations in terms of what really matters to the patient. Let us just inexpensive research, data collection, and of course, patient advocacy. I'll give you a classic example, Lisa. I saw a patient who's 16-year-old who came from town. She couldn't afford a tablet of Indira. So the average annual, income of an Indian family is about $400 per month. So if they buy disopyramide or mavacamten, they have to start the next month because that's the story. There are a lot of things we are talking about, but several of my patients cannot afford this. So that's why I keep talking about what can be done for a vast majority of people who can't afford. That is going to be an important aspect of next year's discussion. And we'll sit and plan about and do a better meeting next time. Thank you very much for participation. And I would like to conclude by saying a big thank you to all of you. Stay safe and thank you.
Thank you. Be safe, everyone.